there are some change of the kind of mass. For example, the multilateral cyst, the presence of solid component, the homogeneity low level, ecogenicity, other type of ecogenicity, are more common in older women. Also, population are more common in older women. And regarding the specificity and sensitivity, this change, but not significantly, during the age of the woman. Is very high in younger ladies, and but decrease after 45 years old in a woman. There are several additional ultrasound features associated with the presence of endometrioma. We speak about this, in particular, hyperechogenic foci in the wall, acoustic streaming, fluid interface, presence of that typical appearance, Crushing sign, and also non-vascularized formation protruding in the lumen. Regarding the streaming, is not typical of endometrioma. The presence of that excludes the presence of an endometrioma, and this is the typical appearance of a non-endometriotic cyst. The presence of crushing sign is usually associated with benignity. In the majority of cases of endometrioma, this finding is present, and this is a typical appearance of a crushing sign associated with benign cyst. There are some hyperechogenic foci in the wall. It's related with the presence of cholesterol and granulation, and this is associated with older endometrioma, in some cases of older endometrioma. And also the presence of fluid-to-fluid interface is a typical of some endometrioma, and represent the hyperechogenic layer associated with blood. There is also, in some cases, protrusion into the lumen, and this can simulate the presence of solid area, papillary formation. And for that, we create an algorithm a lot of years ago. And then the presence of endometrioma is associated with absence of arterial flow in the echogenic portion, and associated with a poor vascularization. In this case, as has been reported by my colleague Caterina Zacustos, we continue to use this algorithm also in present practice. And this a case with this typical hyperechogenic structure in the wall, with totally absence of flow in the majority of cases, and this appearance is present in 70% of cases. This is a very important feature. If you are able to recognize these findings, you can improve a lot your capacity, diagnostic capacity. But you have also to remember the presence, obviously, or more complex, more difficult to identify tumor as borderline tumor are associated in some cases with a granulous appearance. And obviously, we have to be able to recognize this tumor with a great accuracy. And but using the typical pattern recognition or presence of the endometrioma, you can also perform unexpected management of our patient, also because there is a high rate, 30% of spontaneous resolution of this structure, this system that they show a typical pattern associated with the presence of endometrioma. And also in a big study published in Lancet Oncology some years ago, we found a very low risk in case of a typical benign appearance. Obviously, endometrioma is one of these, and to have the very low risk of presence of malignancy or very low risk of torsion. Also, in particular, with looking for the presence of endometrioma, also in this case, the rate of surgery for transformation or changes or for major complication is very low, as demonstrated in this slide. But there are cases of ovarian transformation, ovarian cancer arising from endometriotic cyst, and this is the case of the study from group Antonia Testa that found that borderline and carcinoma arising from endometriotic cyst show a vascularized solid component at the ultrasound. This is very important finding, and we are able to recognize in the majority of cases the transformation of in this patient, malignant transformation in this patient. It's another case of endometrioid adenocarcinoma. But there is also a true atypical endometrioma. This is the endometrioma during pregnancy. It's a very important findings we found, we evaluate some years ago. Is one of our cases. Is a quite frequent findings, but also the prevalence is a totally unknown. But in the daily practice is an important finding. You can help a lot in the management of this mass. This is visualized before the pregnancy, but if you visualize in the pregnancy, there are some problems because you have to recognize the presence of round vascularized papillary projection, and we have to be able to recognize this disease with a great accuracy. This is a typical evidence of the visualized endometrioma. This is one of my cases. This is at the beginning of the pregnancy. This is at the end of the first trimester. You can show that. I can show you a decrease of dimension, but increase of thickness with this rounded lesion in the endometriotic wall. The study, this author found the majority of cases of endometrioma decrease in the size, but some cases disappearance, but the 5% increase in the size. You have to check with a particular attention in these cases. But there is also an important things that they find the endometrioma a tip of the iceberg, because the deep endometriosis is associated with the presence of an endometrioma in the 35% of cases. For that, with this patient, we suggest to use our consensus opinion about the systematic approach with the patient with the suspected endometriosis, and we suggest to use a structural approach, starting from the evaluation of the uterus, evaluating the anexa with the presence of endometrioma, but also evaluating the mobility of the ovary, the touch of Douglas for the presence of sliding sign. Just after that, evaluate the anterior, lateral, and posterior compartment. Because in our concept, it is very, very important that some soft markers, the mobility of the organs, the sliding sign, and are associated with the presence of rectosigmoid endometriosis, but in particular, endometrioma is associated with the presence of rectosigmoid endometrioma and rectosigmoid endometriosis in the 36% of cases. And for that, we have some additional things. It's not sufficient to have an endometrioma, but we have to visualize the presence of presence of kissing ovaries. It's very, very related with the presence of deep rectosigmoid endometriosis. This is the sign. The ovary are so near to evident. It's a very simple to recognize findings. It is a finding associated important findings. The presence is very, very, very high. In this case, with both signs associated, kissing ovaries or absence of sliding sign, we find a sensitivity of 82% with a specificity of 75%. It's very important detection rate for with the use of a soft marker, a screening marker. But how to treat ovarian endometrioma? We have to consider all the picture, all the entire aspect of the imaging that you can obtain in this patient. Obviously, the first medical first line therapy is oral contraceptive, and obviously it's very important to have this medical approach, because the patient can decide several things. For example, wait before to looking for the pregnancy and so on. And in case of persistence, of, for example, of symptoms, you can also suggest other second line therapy as generic analogs. But you also to consider surgery when you have some changes in the ovary, in the cyst, when you have some advice to treat this patient because something has changed in presence of papilla and so on. But in case of treatment before assisted reproductive technology, you have to think a lot, because the surgery is associated, obviously, with, in case of endometrioma, with a decrease of ovarian reserve, and also is very important to be very accurate in the diagnosis, but also to be very to avoid immediate surgery in this patient, because it's a very aggressive surgery for the ovary, usually decrease the ovarian reserve. And also you are suggested to evaluate the fallopian tubes. There is no so agreed evidence, important evidence of this evaluation in the literature. There are some additional score, not starting from the image, but also just from the evaluation of the cyst inside the ovary, but evaluate in general the tubes, but also because the prevalence of tubular endometriosis have a very wide range, associated probably a different modality of evaluation, usually microscopic evaluation, anatomopathological evaluation is probably for that, the wide range, and it's based on relative few studies. Just one study evaluating in particular this kind of tubal evaluation, but the incidence is very low, and also the sensitivity and specificity is not so high in this case. It's probably we have to evaluate better this evidence in the future. And we also a case report published a few years ago, and it is about the presence of microscopic image obtained during surgery. We confirm the presence of suspicion, and this is not a true papilla, but this is the fibula inside an endometrioma, probably for retraction, as demonstrated in this case. This is not a true papilla, but the tube that is inside the cyst, for a phenomenon of pseudocyst there is some papilla inside, but it's not a true papilla, but it's just a tube included in the system. In conclusion, endometrioma can have some different ultrasonographic feature and also may change during in pregnancy. The treatment that I suggest, the first line treatment, is a medical treatment. In case of the necessity of assisted reproductive, or necessity of assisted reproductive technology, I suggest that this approach before surgery in the majority of cases, and also the presence of endometrioma is the evident tip of the iceberg. You can evaluate in detail this patient to evaluate the presence of other localization, rectosigmoid and the uterosacral ligament. I hope that the war will finish soon, but it's just my hope. I'm very sad for this horrible situation. This is an incredible situation. Sorry for that. And thank you very much for your attention.
Thank you very much, Professor Guerriero, for a wonderful lecture.
Thanks. It's a great pleasure to introduce you as last speaker of this session. You are so incredible and not necessary to present to the audience your incredible experience in this field. You are pioneer in the IOTA steering committee and so on. You are from University of Leuven. You are a full professor in gynecology, and you are the best in the field for several. You present so many presentations around the world. You are so. I'm highly happy to introduce you and about endometrioma sonographic examination and the food management. Please, Professor.
Hello, thank you for inviting me to discuss endometrioma, sonographic examination, and further management. First of all, I would like to start with terms and definitions and measurements to describe the sonographic features of an exotumor. So this is the IOTA consensus published in 2000, and this is really the base of our research in order to come to a standardized description of the different ovarian tumors. And Daniela Fischer-Over made very beautiful educational material, which you can find on the IOTA website. The morphologic classification is distinguishing between unilocular cysts, where the risk of malignancy is very low. Unilocular solid tumors, on the other hand, have a much higher risk of malignancy. So as soon as you have some solid tissue inside a cyst or a tumor, the risk of malignancy goes up quite quickly. Multilocular cyst without any solid components, the risk is lower, but around 10%. If it's multilocular solid, then of course the risk is much higher, and also in solid tumors, the risk of malignancy is very high. If you look at the contents of the cyst, then for this lecture, it's important to distinguish between low echogenicity, anechoic tumors, cyst, functional cyst with hemorrhagic components, so where you see blood clots or fibrin threads, and then the cyst with ground glass. So ground glass is a gray appearance, which is typical for all blood and which you will see in endometriomas. The mixed components are much more suggestive of a dermoid cyst or a teratoma, and sometimes in the mixed you will find old blood fluid levels, and that may be in an endometrioma, or fat fluid levels, which you will see in teratoma. And sometimes there's a dirty appearance of the internal echogenicity, and that's something you might see in abscesses or in pelvic inflammatory disease. The benign descriptors have been described by the IOTA group, and here it is important to distinguish between different unilocular cysts, and if it's unilocular tumor with ground glass echogenicity in a premenopausal woman less than 10 centimeters in largest diameter, it's very likely to be an endometrioma. But it's very likely, of course, to be a benign tumor. If you see a unilocular tumor with mixed echogenicity and acoustic shadows in a premenopausal woman, and it's less than 10 centimeters in largest diameter, it's very likely to be a dermoid cyst or teratoma. If it's unilocular anechoic with regular walls, maximum diameter of the lesion less than 10 centimeters, it may be a serous cystadenoma or simple cyst, and in this case, it's also very likely to be benign. And in the remaining unilocular tumors with low echogenicity or other appearances, less than 10 centimeters, it's also a sign of a benign tumor. So these are the benign descriptors. Do we need color Doppler? Well, color Doppler may be useful in distinguishing between solid tissue and non-solid tissue, but it's also a measure of the risk of malignancy. So color score 1 is given when there's no blood flow in the septa, in the cyst walls, or in the solid areas. Color score 2 is given when there's only minimal flow detected. Color score 3 is given when there's moderate flow present. And color score 4 is given when there's really very strong flow present. But beware, there's overlap between the different pathologies. So in the corpus luteum, you may see a ring of fire, so there's very strong flow. And also in cancers, of course, like endometrioid ovarian cancer, you will see color score 4. Color Doppler may be useful to distinguish between different pathologies. In a simple cyst or follicle, there's usually no or minimal flow, so color score 1 or 2. Before the ovulation, the flow is increasing, so color score 3. After ovulation, in a corpus luteum or corpus luteum cyst, you may see very strong circular flow, so the ring of fire. Whereas in an endometrioma, usually the flow is minimal and it's localized, so you see patchy areas of blood flow in the cyst wall. In most benign tumors, there's minimal or rather strong flow in the septa or in the walls. 2 to 3 tubal ovarian abscesses may have a strong flow, and ovarian cancer is usually also associated with strong flow, especially in the solid areas. For example, here you see a unilocular cyst with ground glass appearance, but sometimes you may see small calcifications in the wall. If it's only a very hyperechoic area, this is not regarded as a solid area, because it doesn't have the appearance of solid tissue like you see in the myometrium or in other solid areas. So you're 30 years old, it's a unilocular lesion, 5 centimeters in maximum diameter, ground glass echogenicity, color score 2, so there's minimal flow in the wall. This was a benign endometrioma. And beware, C125, the tumor marker, which is most sensitive for endometriosis, there was a false positive result because if it's high, then people may think that it might be related to a cancer. So the ASHRAE recommends not to use biomarkers for the diagnosis of endometriosis. And this is mainly to avoid unnecessary concerns about a possible malignancy. So tumor markers are not really reliable in this regard. Here you see an endometrioma. On the right, you see the ground glass appearance. On the left, you see fresh bleeding, and you see a blood clot. And this is like a bit like a sail that you can see inside the area, which is more anechoic, but then you see the fibrin threads in between. The typical endometrioma does not contain solid tissue, but sometimes you see some sluggish material in the wall, and then we speak about a non-typical endometrioma. And of course, in these cases, you're always a bit concerned whether this is benign or malignant. At the periphery, you see normal ovarian stroma with follicles, then you see this material, which is measured here, and then you have the ground glass appearance of the old blood. So the big question is to distinguish between benign endometrioma and malignancy. But beware, in benign endometrioma, you have the non-typical endometriomas, as I've just shown, but there's also the residualization of a benign endometrioma in pregnancy. And then suddenly this endometrioma will have papillations with usually strong vascularity inside. On the other hand, malignant tumors may consist of seromucinous borderline tumors, endometrioid borderline tumors, or endometrioid and clear cell carcinomas. So how to distinguish between the two? The first interesting paper was published in 1998 by Stefano Guerriero and colleagues, and they had a simple way to distinguish based on B mode and color Doppler evaluation. So you have the typical endometrioma, so unilocular with ground glass appearance, and the non-typical with this fibrous tissue or sluggish material in the wall. If you then apply color Doppler evaluation and you see flow in this area, then it's usually not a benign, a simple endometrioma. If you see abundant flow, it's also not an endometrioma. But if you have the typical appearance and patchy, so dispersed color flow, color score 2, or no flow in the solid looking area, then it's usually a benign endometrioma. Then came some publications on decidualized ovarian endometrioma, and the second case report was published almost 20 years ago by Professor Testa's group in Rome. So Dr. Fuscella published a case of a patient 39 years old. At 10 weeks gestation, they noticed papillations inside an ovarian cyst. And at 12 weeks gestation, there was very strong flow in this area. Then there's also an imaging in gynecological disease paper, which reports on a number of decidualized endometriomas. And you see that it's very often this qualified as a malignant tumor. So certainly benign only in 70% of cases, probably benign 22% of cases, uncertain 56% of cases, and probably malignant in 6% of cases. But how to distinguish between decidualized endometrioma and a borderline tumor, for example? Well, in decidualized endometrioma in pregnancy, you see rounded, vascularized papillations with smooth contours. So this is different in borderline tumor. Usually the papillations are not very round, and there's not often very strong flow, but there may be strong flow. But this flow makes it very suspicious in the benign decidualized endometriomas. And if they are after the pregnancy, usually this appearance disappears and it returns to a normal appearance of a benign endometrioma. Very rarely, there may be decidualized endometrioma in a non-pregnant woman. This is a case report published 2 years ago. She was 40 years old, a patient. She had no history of endometriosis. And there was a multilocular solid cyst with ground glass heterogeneity, multiple solid components, and there were 3 populations highly vascularized. But beware, the patient was treated with progestogen 14 days per month for 1 year. And it turned out to be an ovarian endometrioma with an edematous intracystic vegetative component showing mucinous and squamous metaplasia and stroma with features of pseudo-decellularization with diffuse eosinophilia. A recent, no, not so recent, publication 12 years ago in the White Journal described ovarian cancer arising in endometriotic cysts. In an endometrioma, there's a higher risk of malignancy. So this is one of the very few benign tumors that may transform into a malignancy. And this happens especially above the age of 45. So endometriomas around menopause should be carefully followed and may be better removed if they persist. And the appearance is shown here. So top level, you see a young patient. She was only 30 years old with an endometrioid borderline tumor that clearly developed in an endometrioma. So the pathologist could find a benign endometrioma here and a borderline tumor here. And below you see a patient 49 years old with endometrioid ovarian cancer that developed in an endometrioma. And again, we wrote an imaging in gynecological disease paper on the ultrasound characteristics of endometrioid ovarian cancer. And there's actually 2 types. So you have the pure endometrioid cancer developing from an endometrioma. And if you look at the images, it's usually quite small solid parts. The solid parts are irregular. And you may see in many cases the typical ground glass appearance of the cyst components. And this is pure endometrioid carcinoma without evidence of endometrioma. It seems that there's more solid tissue, and you may see solid tissue centrally in the tumor with some areas like this. And we, Professor Testa called it the cockade sign. So this is a very typical appearance of pure endometrioid carcinoma without evidence of a pre-existing endometrioma. And then in 2010, we published a case series of 713 endometriomas. So it was a study based on the IOTA study. And out of 3,511 patients with ovarian tumors, the 700 endometriomas were examined, and we tried to find the best rule to distinguish between benign and possibly malignant tumors in so-called or in presumably endometriomas. The adnexal mass in a premenopausal patient with ground glass echogenicity, there may be 1 to 4 loci with or without solid component, but without papillations with internal blood flow, was the best rule to classify most of the benign endometriomas as benign endometriomas. And if you test this rule on the whole IOTA dataset, the positive likelihood ratio was 38, and the negative likelihood ratio was 0.33. So this rule included only 0.4% of malignant masses. So this is what I would propose as the best rule to make the diagnosis of a benign endometrioma. But sometimes it may be difficult. So this is a patient that was seen recently, 25 years old. On the right ovary, you see a large cyst with 2 locules, 1 ground glass echogenicity in the cyst content, and 1 anechoic part. And if you look carefully, you see 1 small papillation in the cyst wall, and there's vascularity inside. So according to the rule that we just discussed, this should not be classified as a benign endometrioma. And at frozen section during surgery, the diagnosis was benign endometrioma, but final histology showed a serum mucinous borderline tumor, AT1C3. If you see an endometrioma, most often there's more endometriosis to find. So the isolated endometriomas without deep endometriosis are quite rare. In this study, for example, of 255 women between 20 and 40 years of age, only 38 patients, so 15%, exhibited only a single isolated endometrioma. So if you see an endometrioma, please look further for signs of deep endometriosis, so deep nodules or adhesions and other areas of superficial endometriosis. In the IDEA group, so the International Deep Endometriosis Analysis, the terms and definitions were published also in the Wired Journal in 2016. And in this paper, you will find a lot of images, pictures to describe the presence of endometriosis. We will not go into this because other speakers have covered this, but this is the anterior component with endometriosis nodule in the bladder wall. So this is the uterus. Here you see the endometriosis, and you can clearly see a white line between the endometriotic nodule. So the bladder wall is between the nodule and the uterus. You see that the blood supply to the nodule is coming from the bladder and not directly from the uterus. If this would be a fibroma, there would be blood supply directly from the uterus. On the posterior compartment, you can see the rectosigmoid, and also here, very often, there's a deep nodule in the anterior wall of the rectum. And it's important to describe it where it is situated, and also whether there's deep invasion or not. For example, this is a case of superficial invasion. You see the muscularis, the black line, and suddenly this is much bigger, so it's a swollen area. So this is the nodule. You see the serosa, the muscularis, and then the mucosa and the submucosa. And in this case, there's no sign of transmucosal infiltration. On the other hand, if you see the Indian Hydra sign, or more recently this has been changed into moose antler sign, then the muscularis is also swollen, but the feathers represent the mucosa and the submucosa, and so more recently this is like the antler of a moose. If you see deep nodes in the anterior wall of the rectum, which is more rounded, and certainly if this is really strongly vascularized, beware, this might be a rectal cancer. So in this case, it was clearly a rectum carcinoma. If you then look at the ovaries, there may be an inclusion endometrioma. In some cases, it's a bit uncertain, and in some cases, it's an invagination endometrioma. So the distinction between the three is not so important, but of course, if you try to move an invagination endometrioma, it will always open when you try to mobilize the ovary. What's helpful in more suspicious cases to distinguish between benign and malignant is the ADNEX model. This was published in 2014 in the BMJ, and it's been based on 6,000 tumors, 4,000 benign and 2,000 malignant tumors. It's based on the age of the patient. The type of center, so oncology center, has a higher risk of malignancy, of course, and also a different mix of tumors. C125 is optional, so you don't need to have it, so it's not mandatory. But if you think it's a malignant tumor, then C125 is helpful, because that could help to differentiate between stage 2 to 4 cancer versus metastatic disease, and also between stage 1 tumors and stage 2 to 4. And there's only 6 ultrasound variables needed for the ADNEX model, and that's a maximal diameter of the lesion, the maximal diameter of the largest solid part, more than 10 cis locules, yes or no, the number of papillations, the presence of acoustic shadows, and the presence of ascites. So let's rehearse this. Largest diameter of the lesion, maximum diameter of the largest solid component measured in any direction. More than 10 cyst locus, yes or no. So you don't need to count them, just see, is this more than 10 or not? Number of papillations. And a papillation is any solid protrusion into the cyst cavity from the cyst wall with a height greater or equal to 3 millimeters. So by definition, a papillation is always solid tissue. But on the other hand, solid tissue is not always a papillation. If it's not protruding in the cyst cavity, it's not a papillation, but it's still solid tissue. And how to count the number of papillations? Well, if you are in doubt, because there's confluence of two papillations, is this separate or not? Then you look at the height. So you measure from the inside of the cyst wall, and you measure the two peaks. And if the valley is less in height than the lowest peak, then these two papillations are really separate. So there's two different papillations. Here's another papillation. So in this area, you see at least 3 papillations. Acoustic shadows, that's clearly visible here in this case of benign fibroma of the ovary. So don't look at the edge shadows, but if there's central shadows, that's what we call acoustic shadows, and that's also a sign of a benign tumor. Ascites is presence of fluid outside the porch of Douglas. So very often you see a little bit of fluid in the porch of Douglas. That's not ascites, but if you see fluid between the bladder and the uterus, or fluid above the level of the uterus, or fluid in the Morrison space when you do a transabdominal scan, then there is ascites. So this is the overview, the 6 ultrasound variable. And then you can do the calculation based on the formula which was published in the paper. So it's free for everyone to use this formula. The apps have been temporarily suspended because of medical device regulation of the EU. And it's luckily more and more integrated into different ultrasound devices. Here you can see a case of a young patient with a unilocular solid tumor with several papillations. She was 23 years old. The lesion diameter is 47 millimeters in largest diameter. There's 6 papillations. The largest papillation measures 10 by 11 by 11 millimeters, and there's no acoustic shadows present. So color score is not needed for the UpNext model. You can introduce the data, and then you get the results. So on the left bar, you see all the IOTA patients in this study. So in 2014, there were 6,000, 4,000 benign in green, and then these are the malignant ones. And this is the individual risk of the patient in the right column, and the yellow part is the risk of a borderline tumor. And you can see that this is clearly the highest risk in the malignant group. So the risk of malignancy overall for this patient is 52%, and it's most likely that she will have a borderline tumor because the relative risk goes up from 6% to 42%, so the relative risk is 6.8. And it was a borderline malignant tumor. So in the first step, you distinguish between benign and malignant. And in the second step, you look for borderline tumors versus stage 1 ovarian cancers versus stage 2 to 4 ovarian cancers and a metastasis, for example, from a breast cancer or gastric cancer or lymphoma inside the ovary. And then you can adapt the management based on the most likely diagnosis. So in a young patient, you may consider fertility-sparing surgery. In stage 1 ovarian cancer, you can do surgical staging, but you avoid any spilling because this would worsen the prognosis for the patient. Stage 2 for ovarian cancer, it's depending on the surgical staging. And if it's clearly a metastasis of the ovary, you could consider a true-cut biopsy, and you certainly need to look for primary tumor by doing a CT scan or whole-body MRI, or you may consider to do a true-cut biopsy of the tumor. So again, First, you look for the aorta benign descriptors, and then, in the second step, if they're not present, you can use the UPNEX model. And the benign descriptors in this study published in 2022, last year, by Dr. Landolfo, based on 4,900 patients in aorta 5. It was present in 37% of cases, and if you see the benign descriptors, 99.3% of the tumors were benign. Then you apply the UPNEX model, and in this case, the area under the curve overall of the two-step strategy was 0.94. So this is a reliable way to distinguish between benign and malignant tumors. And this was true in the different centers. So here you can see the meta-analysis of the different centers. So first step is normal ovary functional changes. That's OVADS 1, normal ovary. If you have the classic benign descriptors, it's OVADS 2, it's almost certainly benign. And if you then apply the UPNEX model for all the other tumors, then you may have a very low risk, so less than 1%, it's also almost certainly benign. 1 to less than 10%, it's low risk. 10 to less than 50%, intermediate risk. And 50 to 100%, it's high risk of malignancy. And based on this follows a logical step regarding the management. So if the risk is very low, you may consider conservative management if the patient has no pain or high risk for cancer, based on a genetic profile. If it's OVADS 3, you may consider surgery, but this may be done locally by ultrasound, by laparoscopy. And if it's OVADS 4 or 5, then the patient is best referred to specialized care in a gynae oncology center. And it's very interesting to look at the guidelines from ESHRE published last year in 22. And if you see an endometrioma and the patient has pain, then there's different options. You can only give analgesics or NSAID, so that's one option. More likely is it that you will propose hormonal treatment, and then you can have a choice between combined hormonal contraceptives, progestogens, GnRH agonist, GnRH antagonist, and or aromatase inhibitors. And if this is not helpful, then you can offer surgery as an option. And after surgery, it's best to give hormonal treatment to make recurrences less likely. But of course, if the patient has infertility, then hormonal treatment is not a good option. Then you may choose either surgery or medically assisted reproduction, so that you offer either IVF or other medically assisted reproductive techniques. And if you look specifically at surgery for endometrioma, there's no randomized controlled trials comparing cystectomy versus no treatment in women with endometrioma and measuring the effect on pain symptoms. But when you do surgery in women with an ovarian endometrioma, clinicians should perform cystectomy instead of drainage and coagulation, because cystectomy reduces the recurrence of endometrioma and endometriosis-associated pain. And with drainage, it's always coming back, the endometrioma. When performing surgery in women with ovarian endometrioma, clinicians can consider both cystectomy and CO2 laser vaporization, because both techniques appear to have similar recurrence rates beyond the first year after surgery. But early post-surgical recurrence rates may be lower after cystectomy. But when doing cystectomy, you need to be careful not to remove too much healthy ovarian tissue. And when performing surgery for an ovarian endometrioma, you really need to minimize ovarian damage. So this is true for cysts, or it's recommended to do surgery in cases where the cyst is at least 3 centimeters of size. More and more this year, we see papers appearing on sclerotherapy for ovarian endometrioma, and this can be administered by ultrasound, or this can be done laparoscopically. But the jury is still out what's the best technique. So I would propose that the possible treatments are discussed with the patient, and that it's really tailor-made care. So if you have an endometrioma and you go for surgery, there may be a cystectomy, and this is most appropriate, I think, for patients beyond the age of pregnancy wish, so 40 years and on, and if there's no suspicion of malignancy, of course. There may be a place for ablation with CO2 or argon plasma, and more evidence is building up for sclerotherapy. And then finally, drainage is best avoided because there's 100% recurrence, but it might be useful in IVF immediate post-surgery. If you do IVF immediate post-surgery, so if the endometrioma is making the IVF more difficult. I thank you for your attention. Hello again.
Hi.
Professor. Professor Guerrero, do you have any questions?
Yes, it's possible. I want to ask the effect of age on the endometrioma. During your presentation, you showed a possibility to remove all the things that are similar to an endometrioma in a woman around 50 years old. But also we can show the risk in our study published some years ago about in human reproduction to miss this case because as Lil showed, in some cases possible of false negative cases of presence of endometrioma because the internal component completely change and the fluid inside become anechoic instead of to be ground glass. But what is your opinion? There's no control study about that, but probably is just safe manner to manage this patient with a suspicion of endometrioma in the late part of the life of the reproductive life.
Yes, I fully agree. I think whenever the patient is above the age of 45 and you see persistent endometriomas, I would feel more safe if this is removed certainly after menopause, because in the IOTA database, we saw that after menopause, if you see a cyst with ground glass appearance, the risk of malignancy is much higher. So there may be a meteoroid carcinoma, there may be a clear cell carcinoma. So therefore, I think this is really a risk factor. And this is also the reason why in the benign descriptors, the benign descriptor 1 is only true for premenopausal patients. So you cannot say it's a benign looking cyst if the patient is postmenopausal. If it's unilocular cyst, ground glass appearance, and it's less than 10 centimeters, but in a premenopausal patient, don't automatically classify this as benign. So I would feel more safe to remove it. And also in the atypical endometriomas, where you have these solid areas, I think it's not a bad idea to remove them in a safe way.
I agree.
There was also a question, but I hope that this has been solved now, to the lecture by Professor Valentin. How can we differentiate a wall nodularity on typical endometrioma and papillation in a malignant cyst? So I think we've seen in the different presentations many examples of the irregular papillations versus the rounded papillations in decidualized endometriomas, so in the benign tumors. So I think if a papillation is irregular, if there's confluence, if it's highly vascularized, you need to be careful. But in pregnancy, even if it's highly vascularized and if it's rounded, don't go for surgery too quickly, because most of the time it's a benign decidualized endometrioma.
Dirk, what do you think to wait at least 1 month when you see some irregularities inside the cyst to be sure there's no to be too interventional to be
true? I think this is a good attitude. Certainly in pregnancy, don't rush into surgery quickly. So wait and see, especially in pregnant patients. It's a very good strategy, I think.
Yeah.
Ligita?
Yeah, I have a question to you, Dirk. You said that you would remove all the endometriomas after 45 or 50, but would you do it also if you, or endometriomas like cyst, if you would have known that the woman had the endometrioma before she turned 45 or 50, and it's still not it, and it remained unchanged? Would it still be like a kind of indication for removal just according to her age, or would you just follow up, and in that case, how often, or what would you do?
Well, in younger patients, we certainly follow it up because if there's an endometrioma, I think it's always a good idea to follow them up at least yearly to see whether there's no malignant transformation, and also to see what's happening to the endometrioma. And like we discussed, it's really depending on the fertility wish or the pain that the patient experiences, whether you go into surgery or not. And of course, every surgery has its risks, so you have to discuss with the patient, and it's a discussion, and you have to balance the benefits and the risks of surgery and the risk of not doing anything. So I think this is really not an easy question with endometriomas, and certainly the atypical endometriomas, to find the right option in every single patient. So it's really not one size fits all. You have to discuss it and look at it in an individual manner.
Dirk, what do you think of the option suggested by ESHRE guidelines? You show you the flow chart for a reproductive problem, for fertility, for a patient looking for fertility. For me, to send directly to the assisted reproductive technology is too much. Probably when they found an endometrioma, I wait at least 3 months, 4 months for natural conception. What do you think about that?
I agree, because it's not because there's an endometrioma that the patient cannot become pregnant. So I think it's always a good idea to try to conceive in a natural way. And if this fails, then you can go further to assisted reproduction or to surgery.
Because there are a good paper about that with natural conception, with the presence of the normal ovulation and so on. It's probably is a good option to wait because to avoid to be iatrogenic. It's our problem in the last 2 years.
Okay, so there's another question. Please discuss about bowel preparation. Is it needed or not? What are the pros and the cons? And some centers have it in the protocols, others have not. So what about bowel preparation?
Well, now there is a study published from Simone Ferrero and colleagues about that. He's demonstrated there is no difference between preparation or not. Obviously, there are a big group in the South America and Brazil and so on. They use also in Australia, they use a lot bowel preparation. But in my personal opinion, I'm not sure, because the problem is the lesion, rectosigmoid lesion mainly, is in the anterior wall. And it's probably the bowel preparation does not interfere with this appearance, because it's so near to the probe, and it's good to follow the lesion without any kind of preparation. Another things I noted, but there's not true evidence in the literature about that. There is an incredible overlap between the symptoms and also the appearance of irritable bowel syndrome, and perform enema before the evaluation in some cases interfere a lot with this bowel irritable syndrome of this patient. That's probably I have some problem with the quality of the image after bowel preparation in the majority of cases. There is no evidence, but there's the practical evidence in everyday practice. That's my opinion for that.
Okay, I would like to ask a question to Dr. Ruben Heremans, who is here with us, and I'm very happy about this because he just returned from 1 year in Australia, so he knows what's happening in Australia. And he's also almost finished with his PhD on AITA, so endometrial tumors, but of course he has a keen interest in other gynecological problems. He's also the first author of the paper that we've just seen on teratomas, on benign cystic teratomas, the imaging paper. So Ruben?
Yeah, I had a question to the panel myself as well. And as with bowel preparation, serves to accentuate any lesions. But there's an interesting, thought-provoking and actually perhaps practice-ameliorating paper by Matthew Leonardi and George Condas, and it's about sonopodography. I was wondering whether perhaps Professor Guerriero, whether you could share your view on that, because it's a form of fluid installation.
I discussed with Matthew about that, because for me it's too invasive to put some fluid. Obviously, if you do for other reasons, but usually the patient with suspicion, superficial or uterosacral ligament lesion are very young, with any kind, not looking for pregnancy. And for that, put some saline inside is not so good. The good things that we have discussed for that with the Matthew is that the majority of girls have some fluid inside the pelvis, and the fluid is a friend, as some people say a lot of years ago, and for ultrasound, and you can spend some time to move the inside the pelvis, the fluid from one side to the other side using your second hand, and you can, in some cases, you can obtain beautiful images. It's probably the idea is good, but because of fluid is friend, but there are the fluid necessary to see some very small lesion is very small amount of fluid inside, not large amounts, and for that. Also because there is also the problem with extravasation. It's better to avoid to put a lot of saline inside the uterus. This is my opinion.
Okay. And with regards to uterosacral visualization, we've seen from Professor Wollman that he starts his search from the torus, from the midline, and then moves his way to the side. From the way that Matteo Leonardi and George Condas described in a paper, they go about it more in a sagittal plane. What would your approach be?
I use both methods. The good thing, I agree completely. Also, I look at Savelli paper about that. Please avoid to push too much the uterosacral ligament. If not, you can stretch too much the disappearance. We have to very gently, always, in case of suspicion of deep endometriosis or a lesion like that. But you can be the pressure is not a friend. Okay, you can move slowly, and you can emphasize some very superficial lesion or deep lesion, depending. Probably you can start as you want. I suggest always to start in the same manner if you're not an expert, because for me the structured approach suggested by IDEA consensus is probably the most important things of this consensus. As probably to be repeat all the same procedure in the same manner, evaluate the uterus, evaluate the ovary, mobility, sliding, and after to move to the anterior and posterior compartment. This is mandatory approach in the mind of the people that start to evaluate this patient. After you can move up and down, but it's probably to be maintain an order it's a good option.
Absolutely. Okay.
Ligita, you had a question on reporting endometriosis, the findings. So in the chat you wrote, what's important to report? I think idea, terms and definitions is a good way to start your report by sticking to the terms and definitions and the areas that need to be described. I think it's all in there. And as a classification system, I think Professor Valentin convinced us that ANSIAN hashtag is a very good classification correlating with the difficulty of surgery. So I think this is it for now, but I'm really looking forward to the big idea studies, the results, to see what's really important, because it might be that some of the descriptions are not relevant or might not be reliable, and then we can omit them, because as simpler that we can make things, the better. But of course, don't make it too simple, because then you lose important information.
Yeah, that was good comment. Thank you.
And then there's also a question from the participants. Does MRI characterizes atypical endometriomas better? You have any comment on the usefulness of MRI?
What do you think?
Well,
MRI usually used for endometriosis, used without contrast.
yes.
Usually, there is some evidence that there are some suggestions. Obviously, in this case, it's completely different. What do you think, Dirk, about that?
We're now waiting for the results of the IOTA MRI study, where we look at MRI as a second line after ultrasound to see in which cases MRI could improve the diagnosis. But we haven't seen the full results yet, so this is for the very near future. But you're absolutely right, Stefano, that in MRI you can look for lesions. But if you want to distinguish between benign and malignant tumors, then you need to have the ADNEX MRI protocol, and that means that you need to have a specific protocol with contrast, with intravenous contrast agents. And you cannot have both at the same time. So people are often confused. They think, I will do an MRI and then I have all the answers. But for example, in Leuven, we have to choose. If we say it's an IOTA MRI patient, where we would like to see whether it's benign or malignant, then it's a different sequence from if you ask, for example, for whole body MRI to see whether there's metastasis of the tumors. You have to choose, and you cannot have everything at the same time with MRI. So it's not, again, solving every question.
Yes, it's an idea of the gynecologist. I think it's the idea of the gynecologist that problem-solving MRI, but there is not always this concept. You have to be to select the question and to have the correct answer.
Yes, and the right radiologist as well, because it's also operator depending.
Yeah.
And yeah, contrast agents precluded in pregnancy, right? So
yes.
Yeah.
So in pregnancy, it will not help you much, I think, to distinguish between benign and malignant. Okay, I think we have perfectly sticked to the time. I thank you very much for the interesting session. I think it's very important for patients. It's very important for the colleagues, for the participants. I hope they enjoyed it. I personally enjoyed it very much. I thank the speakers. I thank you for the discussion. And I think now we come to the coffee break or lunch break if you're a bit hungry. And then in the next session, we will start again with Dr. Ruben Heremans and Dr. Lilith Horspeyan from Armenia.
Okay.
Have a nice lunch.
Coffee break.
And thank you so much.
Bye-bye.
Bye-bye.
We had a dream of Sonio, and Sonio made it.
Sonio, pour moi, c'est vraiment la sécurité de l'examen. Voilà. C'est aussi un gain de temps et un gain de concentration, je dirais.
With Sonio, we cover everything from screening to quality control to workflow to improving doctor-patient relationship and to improve the expertise of a doctor in rare situations.
Hello. Back to the third session of this gynae ultrasound program of the Extempore Congress. The speaker here, the first speaker, is Dr. Ruben Heremans, and he's preparing a PhD on the AITA study, so on endometrial tumors. But luckily, he took interest also in teratomas. And teratomas are benign tumors that we see very often in young patients. And for years, we thought that everything was clear, that we could recognize most of them, but still he managed to find new clinical and ultrasound characteristics of ovarian mature cystic teratomas. So Dr. Ruben Heremans, please present your lecture. Maybe one thing, you have just started as a staff member in Maaseik, so it's close to Genk in Belgium. And I think you've done a great traineeship here in Leuven and also in Australia. Please go ahead.
It's my pleasure and a true honor to be provided here with this forum here today, in which we once again find ourselves united through our passion for ultrasound. Thank you to the organizers for assembling so many passionate experts who gladly dedicate their time to share their views on such a fine and diverse selection of topics. Now, through those muted microphones, I can hear you think out loud though. What on earth could I have possibly missed? In recent times on clinical or sonographic features of mature ovarian cystic teratomas? You know, once we've seen one, we think we've seen them all, right? After all, we've been describing these and what they look like since 1976, haven't we? But could it be that international multicentric collaborations and rapidly evolving ultrasound equipment have now enabled us to see and understand things in a way that we haven't or weren't able to before? Now, let me start off by disclosing that I have nothing to disclose except for my gratitude for your attention. The most prevalent of the ovarian teratomas are the ones that are mostly and interchangeably referred to as mature cystic teratomas or dermoid cysts. These are benign germ cell derivatives, and as you may know, teratoma is derived from the Greek word teras, with its genitive teratos, which can be understood as monster, but also as marvel or as wonder. Beauty is in the eye of the beholder, right? The use of this moniker for these type of cysts stems from the fact that these cysts are composed of tissues derived from a multitude, at least two, of embryonic stem cells, either from the ecto, the meso, or the endodermal tissues. This is unlike monodermal teratomas, who are understandably derived from cells of only one single line of origin. The ectodermal component could be composed of hair, sebum, cartilage, nails, and even neural or glial tissue. And in terms of mesodermal elements, you would be able to appreciate bony elements or striated and smooth muscle cells. And endodermal cells, sometimes the cells that you can see are within the cysts are thyroid or intestinal glands. And things can even go as far as resembling a small human, which is then called a homunculus or a fetiform teratoma, which is not the same as a fetus in fetu. Now, the crux is that all these elements, but especially the neural tissues found within the cysts, are mature, as these are the ones that are graded and the ones that will be the ones to decide between this being a mature, benign mature cyst versus a malignant immature teratoma. Mature cystic teratomas also have an astonishing way to come to existence through what we believe is parthenogenesis, which is a natural form of asexual reproduction. Now, how this exactly occurs within the ovary is understudied, But one hypothesis is that the secondary oocyte fuses again with the nuclear pole that is then located in the zona pellucida, that it had extruded just before, and then initiates meiosis 2 on its own. This is in a way sort of a feminine counterpart for androgenesis, as is seen with complete hydatiform moles. Now, mature cystic teratomas or dermoid cysts are the most common ovarian neoplasms, and they account for 20, and according to some, even up to 44% of all ovarian neoplasms. The crude incidence has been reported to be around 9 cases in 100,000 women, and they make up over 2/3 of women with adnexal pathology below their 20s. Dermoids can occur at any age, but they have been mostly seen in women between 20 and 40 years old. And 15% of women will have teratomas on both ovaries, either concomitantly or consecutively. Now, how do these cysts reveal themselves, and what inconveniences do these cysts bring about? Well, most of them, which is up to 70%, will actually be incidental findings in completely asymptomatic women who undergo a scan for unrelated purposes. If they do become symptomatic, they do so by causing pressure pains or bulk symptoms, or by undergoing torsion or cyst rupture. These painful events mostly have to do with the cyst dynamics. And by mentioning this, I don't want to steal Professor Hovsepian's thunder, who's up next and will talk to you about growing teratomas. But I do want to quickly mention 2 studies discussing the growth of such cysts. In one study, the authors posit that in premenopausal women, cysts below 6 centimeters tend to grow at an average rate of 1.8 millimeters per year, whereas they would decrease by 1.6 millimeters per year after menopause. Another group states that irrespective of menopausal status, these cysts have the proclivity to grow at 0.09 millimeters per month, which is about 1 millimeter per year. Other possible complications that can be cyst infection or cyst recurrence, and it's believed, however, that the latter has to do with the completeness of the removal of the cyst wall, and this could mount up to 8%. Now, the lesser known complications, the zebras, if you may, can be that upon cyst rupture, the caustic contents of the cyst irritate the peritoneum and initiate a granulomatous inflammatory reaction, as the one that is seen by tuberculosis. This is a more insidious process, but one with possible dire consequences in case of bridle formation or intestinal obstruction due to associated inflammation. Other rarely described complications are paraneoplastic. For instance, there's a well-documented association between a rare form of encephalitis and ovarian teratomas, in which the ovarian cyst generates antibodies against the NMDA receptor, or cases of autoimmune hemolysis have been described with the positive Coombs or direct antiglobulin test due to antibodies directly targeting the red blood cells. There's also gliomatosis, peritoneal gliomatosis, which is a perfectly benign condition characterized by the presence of a multitude of peritoneal and omental implants composed of mature glial tissue. And then, of course, there's the complication that's dreaded and feared by all, the zebra to rule all zebras, and that's malignant transformation. Now, fortunately, this remains an extremely rare event, and it's less than 1%. And it will be mainly owing to the development of squamous cell carcinoma in the ectodermal cyst compartment. As we dive into the macroscopy and the microscopy, the top left pane shows a removed dermoid cyst. When this cyst is subsequently opened up, one can appreciate the presence of hair, keratinized tissues, and alongside sebum, as seen on the glove and on the cyst wall surface. If we look a little closer under the microscope, we're able to appreciate exfoliated keratinocytes, squamous epithelium and sebaceous glands, as well as ciliated epithelium and intestinal epithelium. Now, the sonographic features, as well as some of the clinical aspects that I would like to point out to you, are the fruit of the collaboration of many bright foregoers. We published our findings based on the IOTA studies in the White Journal, and we've procured a more concise depiction in Issuog's visual encyclopedia called Visuog. And I invite you to access these via the QR codes that I've shown on this slide. In this study, we looked at histologically confirmed cases of ovarian mature cystic teratomas from 5 centers specialized in gynecological ultrasound over a time span of nearly 2 decades. We looked at prospectively collected clinical and ultrasound features and asked all collaborators to send us their images for us to scrutinize them for new pathognomonic features as well as other remarkable features, which are rather not reminiscent of benign dermoid cysts. The images were assessed by 2 different independent examiners with different levels of expertise, and in case of discordance, the help of 2 ultrasound experts was sought to reach consensus. This is the study flowchart, and as you can see, and as you may know from what's already been published, the IOTA studies are meticulous and broad in the variables that they prospectively collected. And to this part, we added the part in which we scrutinized the images that the collaborators provided us with for features that, 1, have already been described in literature, 2, appear to be recurrent but have not been named yet, and 3, other features that are, as already said, typical, well, rather not typical for your average dermoid cysts. Now, in general, and across all IOTA phases, women with dermoid cysts were young. On average, they were 33 years of age, and only 1/3 of patients presented with symptoms. On average, dermoids were a little over 6 centimeters, but could reach a considerable size, as much as 310 millimeters or 31 centimeters. Cysts were mostly seen as unilocular, but some were thought to be multilocular or even multilocular solid. And the solid components were on average about 2 centimeters, again spanning a wide range. Dermoids mostly displayed little to no vascularity on Doppler interrogation, but in up to 1/5, they did show moderate to abundant vascularity. Shadows were present in most cases as a typical reassuring feature. Both ovaries were affected in 12% of cases, which is congruent with previous sources. Pelvic free fluid was also seen in 1/5 of cases, but rarely ever was there any ascites. An accretion sign showing surrounding unaffected ovarian tissue was seen in close to half of cases. In the absolute majority of cases, cysts showed mixed echogenic content. They were deemed to be certainly or next to certainly benign for most of the time, and the histological outcome was correctly assumed during the majority of examinations. But what makes the brains of expert sonographers? What makes it that they can so easily distinguish dermoid cysts from any other cysts? Now, most of it really boils down to pattern recognition. So let's go through what our quest for patterns brought about. Because besides the previously discussed variables, which were prospectively collected in all consecutive IOTA phases, dermoids are known to share other typical ultrasound features as well. Firstly, there's on the top left, there's the bright white dots and lines, which by some called the dot dash sign or the dermoid mesh sign. And this represents echoes generated by hairs that are perpendicular or parallel to the scanning plane. Secondly, on the top right, there's the echogenic white ball that's also denominated a Rokitansky nodule. It's a rounded hyperechoic intracystic spheroid that can be mobile during scanning, and it's also referring to a compacted ball of sebum with or without teeth or hair. Thirdly, there's a possibility of there being a fat fluid level, which is a sharp demarcation between an anechoic and a hyperechoic plane, and sometimes mobile when the patient moves. And lastly, there's the tip of the iceberg sign, which arises as shadows fall over the lateral and distal borders of the cyst, allowing visibility of only the border that's most proximal to the transducer. I'll put these here on display with some more fitting examples, and then you can see the dots and lines on the top row, the echogenic white ball in the middle, and the fat fluid on the bottom row. On the next slide, you can see some of the very few possible cases of the tip of the iceberg sign that still remain. Now, despite that this has been such a highlighted ultrasound pattern in the beginning days of ultrasound, improvements in ultrasound settings are likely to have caused that there's really a significant reduction in its occurrence. Also, because of the fact that the definition is unclear as to how many borders can be visible and from how many angles of insonation, there should be obscuring of any of the borders. We decided not to report on this ultrasound feature. Now, three of the four historical patterns therefore remain, in which the classic dots and lines were seen in 71% of cases, the echogenic white ball, which was present in 41%, a fat fluid level, which could only be discerned in 1%. And as said, the tip of the iceberg sign was not assessed for this study. Now, as for the new patterns, we would like to introduce four new concepts. Firstly, there's the cotton wool tufts, which are avascular, billowy, and irregularly shaped hyperechogenic foci attached to the cyst wall or stably afloat in the middle of the cyst. Secondly, on the top right, there is the mushroom cap sign, which is formed by an avascular dish-like flattened out hyperechoic zones that follow the curvature of the inner cyst wall. Thirdly, there's the completely echogenic lesion, which is self-explanatory. And lastly, there is the starry sky sign, which is seen as a cyst filled with a myriad of focal hyperechoic spots. Here you can see the pectogram, a visual representation, and two examples of cysts with cotton wool tufts on the top row. On the second row, you can see the same for the mushroom cap sign. The one below shows the same for completely echogenic lesions, and the lowest row, the bottom row, shows the starry sky sign. Now we can share that we retrospectively recorded 38% of cysts to have the cotton wool tufts, 22% to feature a mushroom cap sign, 9% to comprise an completely echogenic lesion, and 6% to show a 0.6% to show the starry sky sign. Other features that we came across, ones that were not particularly reminiscent of typical dermoid cysts, were the presence of vascularized solid tissue, vascularized septa, and also plain multilocular cysts or unilocular cysts without any of the features that I've just outlined throughout this presentation. This slide here depicts the impact of how these typical features could have possibly reassured the original examiner, who were more frequently suggested the specific diagnosis of a dermoid cyst when the typical features were present, even in cases when vascularized solid tissue could have been seen. Remember that we're now trying to retrospectively get into the original examiner's head, right? This is a retrospective detail. Now, it partly impacted how the original examiner felt about the cyst in terms of it being benign or malignant, uncertainty with regards to that matter. Now, based on a historic experiment and to better our own understanding of how we can recognize dermoid cysts, we decided to replicate the findings of Moshe Bronstein and colleagues. For this, all we needed was some hair, butter, oil, rubber gloves, a kidney dish, and the appropriate ultrasound equipment. Using this in vitro model, we were able to replicate many of the ultrasound patterns we've just discussed. Take notice, for instance, how the oily substance is afloat above the water, or how the hair and butter admix into an echogenic white ball that casts a dark shadow. See on the middle pane, on the middle down and upper right two panes, how the crescent of butter attaches to the glove, or how in the bottom right pane a completely echogenic white ball can be seen. Now, to conclude, what I would like you to remember from this study is that dermoid cysts are usually unilocular cysts that are poorly vascularized, have a variable and mostly mixed echogenic content. They can be diagnosed with high accuracy, notwithstanding their typical and atypical presentations, of which the most typical presentations usually are the presence of dots and lines or an echogenic white ball. And with this, I thank you for your attention. And I will gladly take any questions that would have come to mind by now. Thank you.
Okay, we move on to the next speaker. Is Professor Lilith Ovsepian from Ereburi Medical Center in Yerevan, Armenia. Please, Professor, start your session.
Hello, dear colleagues. It's a great honor for me to be here today, and thank you very much to the organizers for this invitation. Today, I want to introduce you interesting pathology. It's a growing teratoma syndrome. But before the presentation, let me introduce you a case of 29 years patient with abdominal pain and irregular periods. Now, let's watch the video. As you see, it was a case of immature teratoma, high-grade FIGO stage 1C1. We know that immature teratoma is a germ cell tumor which accounts for 5% of all ovarian malignant tumors. There are different types of germ cell tumors. There are dysgerminoma, yolk sac tumor, immature teratoma, embryonal carcinoma, malignant mixed germ cell, choriocarcinoma. Immature teratoma, it is a malignant germ cell tumor consisting of a teratoma containing variable amounts of immature tissue, typically primitive neuroectodermal, and represent less than 1% of malignant ovarian tumors. It is composed of tissues derived from all three embryonic layers, the endoderm, mesoderm, and the ectoderm. On the basis of the presence and proportion of immature neuroepithelial tissue, immature teratoma is graded from grade 1 to 3. The grade and stage of these tumors have been shown to be of prognostic significance and are important in making therapeutic decisions. Immature teratoma can occur in children as young as 1.5 years to adult women as old as 60 years, but the mean age at presentation is around 27 years. Clinical features associated with symptoms of rapidly growing abdominal mass and most frequently present with rapid abdominal distension, abdominal pain, and irregular periods. Prognostic factors: older age at diagnosis, higher stage, and high grade confer worse prognosis but overall improved after chemotherapy, with 72% survival for stage 4 disease. In a study of 98 pediatric patients and 81 adult patients, there were no relapses in grade 1 patients, irrespective of stage or age. So grade is the most important risk factor for relapse across all age groups. In patients with grade 3 tumors, recurrence rate was 21% in the pediatric cohort, 20% in the adult cohort, and was significantly associated with stage. Gliomatosis peritonei, it's a phenomenon of immature teratoma, and 25% of cases with immature teratoma have peritoneal implants composed of mature glial tissue, gliomatosis peritonei. This phenomenon is thought to arise from metaplasia of submesothelial cells in response to growth factors secreted by the ovarian tumor, rather than a true metastatic process. Prognosis is good and the presence of nodal gliomatosis doesn't warrant chemotherapy, although with presence of gliomatosis peritonei or lymph node gliomatosis, there is a higher risk of recurrence. Macroscopy. In the pathology literature, they have been described as mainly unilateral tumor, approximately in 80% of cases. More than 90% are diagnosed at FIGO stage 1 with a mean size of 160 mm. There are also large cystic solid or solid with cystic areas or mostly solid tumors with mature teratoma in contralateral ovary in 9% of cases and with hemorrhage and necrosis on cut sections. Microscopically, they can be found in pure form or as a mixed germ cell tumor. When mixed, immature neuroepithelium is the most frequently detected component. Laboratory. What about laboratory tests for immature teratoma? Very specific low-level increase of alpha-fetoprotein, because high levels of alpha-fetoprotein suggest the presence of a yolk sac tumor component, mixed germ cell tumor. Ultrasound. This is a retrospective study of patients with a histological primary diagnosis of pure immature teratoma of the ovary. Clinical databases of 7 centers were searched to identify patients who had undergone a preoperative ultrasound scan. 22 patients were included from 1998 to 2016, of whom 13 were examined within the framework of IOTA studies phases 1-5. Lesions were all described using terms and definitions of the IOTA group. All immature teratomas were unilateral. Alpha-fetoprotein blood levels were increased. The median largest diameter of the lesion was 178. Using IOTA terms and definitions, most were multilocular solid or purely solid tumors, and all the masses showed poor or moderate vascularization. The most typical feature was very heterogeneous echogenicity of solid tissue. And conclusions: immature teratomas of the ovary at ultrasound examination are large, unilateral, cystic with large solid component, or purely solid with heterogeneous echogenicity of the solid components, moderately vascularized adnexal masses. In another article on ultrasonography, the predominant features of immature teratoma were the size of the tumor were large, with a median diameter 115, unilocular solid with fluid of low level echogenicity. The solid mass typically contains multiple small cystic spaces. The solid mass was heterogeneous with fine hyperechoic spicules and occasionally small foci of fat. So keep in mind, rapidly enlarging adnexal mass in a young patient with mildly elevated alpha-fetoprotein and with typical radiological findings raises the possibility of immature teratoma. Now, let me speak about the growing teratoma syndrome, what it is, and I want to speak about that because in some cases it can be the consequence of immature ovarian teratoma. In 1982, Logothesis et al. Discovered a rare condition called growing teratoma syndrome in patients with stage 3 testicular germ cell tumor. This condition remains poorly known, with most of the reports consisting of case series with few patients. Until now, there have been approximately 100 cases of ovarian growing teratoma syndrome reported in the literature, most of which are sporadic case reports. It is characterized by the presence and proliferation of mature teratoma components in metastatic lesions during or after chemotherapy for immature teratomas or mixed germ cell tumors, with only mature teratoma on histological analysis of the resected tumor specimen and with normalization of blood tumor marker alpha-fetoprotein. Because testicular cancer is more frequent than ovarian germ cell tumors, GTS occurs more commonly in male patients with non-seminomatous germ cell tumor. It is rare in female individuals. Most common sites of involvement after the chemotherapy due to immature teratoma, the growing teratoma can be found in other locations such as retroperitoneum, pelvis, chest, and liver. How long does it take for tumor to start? It's very variable regarding disease time course, which can start during chemotherapy, after a large disease-free period, or after an initial reduction in size during chemotherapy, followed by regrowth. Bentivegnem et al. Reported the largest series of growing teratoma syndrome in malignant ovarian germ cell tumor, and in their study, 19% of cases with immature ovarian teratoma experienced GTS. The mean delay between immature teratoma and GTS was 7 months. Another article published by Bonazzi et al. 18% of patients with immature teratoma developed growing teratoma syndrome. In publication of Dan Wang, the incidence of GTS in patients with immature teratoma was 20%, nearly the same. It seems that the prevalence of GTS in ovarian germ cell tumor was higher than that reported in testicular non-seminomatous germ cell tumor. The time of GTS onset was within 24 months from the initial surgery in most cases. GTS tumors vary in their growth rate and their clinical behavior is unpredictable. They can appear during the early course of chemotherapy or as late as 12 years post-chemotherapy. Etiology. The etiology is still uncertain, but there are two main hypotheses described in the literature based on the assumption that embryonal cells are pluripotent and that their origin results from differentiation of tumoral cells. One theory states that chemotherapy may induce the differentiation of malignant cells into mature components. Another one, that chemotherapy may induce the selective destruction of malignant components of tumor, leaving mature components that are resistant to chemotherapy. Risk factors for that. Some conditions that may predict the development of growing teratoma syndrome in patients with germ cell tumor, and they are the presence of mature teratoma components in the primary mature teratoma, histological grade 3, clinical stage higher than stage 3, incomplete resection of the primary tumor splitting during surgery, presence of gliomatosis peritoneae at the time of primary surgery for immature teratoma, and adjuvant chemotherapy after primary surgery for immature teratoma. The ultrasound features. There is no any description in the literature about specific ultrasound or MRI features of growing teratoma syndrome after chemotherapy for immature ovarian teratoma. Treatment. Chemotherapy is a therapeutic option for residual immature teratoma, but it is ineffective for GTS. GTS doesn't respond to chemotherapy and can be the origin of secondary tumors. Chemo-resistant nature of GTS makes additional cycles of chemotherapy ineffective. Surgical resection is currently the gold standard treatment for GTS. Surgical resection is performed to relieve pressure on surrounding organs. Failure to promptly intervene leads to death from either compression of vital organs and or subsequent malignant transformation. Thus, early recognition is critical to prevent fuller systemic therapy and to allow for readily surgical planning. Despite the large tumor burden, complete resection is reported to be often curative. Although there is a low risk of malignant transformation, which was reported to be 3–5%. Growing teratoma has been reported to transform into sarcoma, adenocarcinoma, carcinoid tumor, and primitive neuroectodermal tumor. The prognosis of completely resected growing teratoma is considered good and is often curative, with the 5-year survival rate is considered to be around 90%. Differential diagnosis. The main differential diagnosis with increased immature teratoma component due to ineffective BEP therapy. Now I want to continue the case report and to show you how, this case report in more detail. So again, let me repeat, the 29 years patient with abdominal pain and irregular periods with increased tumor markers, alpha-fetoprotein and CA125, with after laparoscopic right adnexectomy, which was performed due immature ovarian teratoma. Final pathology report was immature ovarian teratoma, high-grade FIGO stage 1C1. And due to FIGO stage 1C1, 4 cycles of adjuvant chemotherapy, BEP therapy, was performed. 5 months later, after primary surgery, immediately after finishing the chemotherapy course, recurrence with normal tumor markers occurred. Now, let's watch the second video, a continuation of the same clinical case of immature teratoma, the first part of which you watch at the beginning of the lecture. Let me also show you the CT scan images in different planes with the tumor, and also the tumor you can see in a sagittal plane on CT scan, and also the MRI images in different planes with the tumor. My conclusion that growing teratoma can have the same ultrasound features of mature teratoma, because in most cases it consists from a fatty tissue. And take-home messages: GTS is a rare condition related to both testicular and ovarian germ cell tumor. The incidence of GTS in ovarian immature teratoma is around 20%. Residual disease and presence of gliomatosis peritoneae at initial surgery are independent risk factors for GTS development. Optimal debulking surgery is the cornerstone of treatment at the time of GTS diagnosis. Patients with GTS should be transferred to experienced centers with multidisciplinary surgical team. The overall prognosis of GTS is excellent. However, due to the rarity of ovarian immature teratoma and GTS, the etiology and clinical behavior of this syndrome is still poorly understood. So that's why in future an international multi-center study including a larger cohort is warranted to investigate this rare disease on a molecular, pathological, surgical, and therapeutic level. Close imaging surveillance is crucial for early recognition, particularly in patients with risk factors. And thank you for your attention.
Thank you very much to both speakers for wonderful lectures. I really enjoyed it. First of all, Ruben, the tip of the iceberg sign, is it a really specific sign? Because you say we stopped advocating it for the diagnosis of teratomas.
No, indeed. Yeah, it is not specific. Back in the 70s, when actually Paul Goodman was the one to coin the term from Stanford University. He already had 3 false positives. They concluded this sign on a series of 20s. And then already 3 false positives, because you could imagine that like ovarian fibromas would be able to cast a shadow as deep as those ones as well, which was rightfully so the reason why among the notable experts who we sought information said to omit this sign due to the rapid progression of ultrasound techniques, and that it was just a sign that was just too poorly documented or difficult to document in a reliable, replicable way, so to speak.
Okay, so it was said before, fluid is your friend, but I think calcifications are also our friend. So if you see calcifications in fibromas, in a dermoid cyst, in ovarian tumors, it's a sign of benign tumors. But of course, not any sign is completely reliable, so nothing is 100% in ultrasound. But it's true, it's most likely to be a benign tumor, and most of the time it may be a teratoma, but it can be other things as well. I especially liked your in vitro ultrasound. It reminds me of the creative cooking of our children. this is creative in vitro ultrasound. So it's beautiful how you can mimic the signs of an endometrioma, of a teratoma, by using butter and other ingredients.
Already done. Also, I prepared some years ago similar things to be sure the presence of fat inside, using gloves and so on. It's very, from the study from Israeli people there, it's very interesting. I have just a question, Ruben, for you. Do you think for the people that start to evaluate and start to at the beginning of the learning curve, do you some typical finding you could try to find inside the cyst, most typical of presence of dermoids? For example, in my experience, I try to teach to the residents that dots and lines are very it's so typical. And do you agree with this, or because some are difficult, because hyperechogenic, no, obviously echogenic spots are important, usually not always, because not always are related with benignity, but benign cyst. But I think that it's difficult to have dots and lines inside in a malignancy, for example.
Absolutely, surely so that dots and lines, they were present in some 70% of cases. So all the other IOTA collaborators would agree with you as well, and us during our retrospective query, we fully agree with that. And subsequently, a hyperechogenic avascular echogenic white ball, the Rokitansky nodule, and then the cotton wool tufts were even more prevalent than the mushroom capsine. But like you could think that like these like the haphazardous organization of the cotton wool tufts, they might seem a bit scary, but once you recognize them as a pattern and notice that they're completely avascular, they're completely reassuring findings. With that being said, there being hair, etc., in a malignant cyst is, well, it is however still possible, but then you would see that more in immature teratomas, and you would see, as Professor Hovsepian discussed, the very heterogeneous but then solid tissue. Which
you have to spend time to manipulate the ovary in the right manner to emphasize the presence of this sign. You have to, for that, the pattern recognition is relatively easy, but always, for me, the presence of teratoma is very important from the. But you have to have more education. The learning curve not so easy as, for example, the majority of endometriomas and so on. And for people, I think it's a difficult lesion. It's one of the most difficult pattern recognition, I think. But when you are able to recognize, you are so happy because you are in the majority is benign cyst. You can live there, and I think it's a very important step to recognize a dermoid cyst.
Absolutely. And also, I absolutely adored everything about Professor Hovsepian's presentation. I don't know about you as experts, but I have personally never heard about the growing teratoma syndrome before. It's absolutely magnificent. It's very striking, though, to me that like the growing parts after that chemo knockdown are actually the mature elements that are growing. It's very strange.
For me, it also was very strange until I met this case last year, and we was sure that it's a recurrent tumor. So after the secondary surgery, when we performed the cytoreductive surgery, and when we got the final pathology report, it was really amazing.
Yeah, because it sort of left you like with very few like mature features, right? On ultrasound, you could only go by the fat in retrospect after having removed the ovary subsequently.
Yes. And so now I understood that the ultrasound features of growing teratoma syndrome is completely the same as mature teratoma, because there is only the fat tissue in the tumor.
Yeah.
We just only need to keep in mind that if we have a patient with immature teratoma who go to underwent of chemotherapy, we can keep in mind that there is a not very high, but around 19-20% of chance that we can have a growing teratoma syndrome after the chemo, even during chemotherapy or immediately after chemotherapy, or 1 year or some months later.
That's so impactful, because imagine the age of these patients. They're nearly all of reproductive age, so can mean so much. Yeah.
It was a truly excellent lecture indeed, and it's very novel. And do you have any suggestion of how to follow up patients after immature teratoma? How often? Ultrasound? You also showed CT or MRI. Is it useful, or can we do only ultrasound? And how often should we do it?
In our unit, we have a gynecological oncology tumor board. And in our team, we usually perform the ultrasound follow-up every 3 months after surgery. First 2 years, and then 6 months, every 6 months after 2 years, during 1 year, and then after yearly during 5 years. And we usually also perform the CT scan for follow-up once every year, but we don't perform MRI. We use ultrasound and CT scan.
Okay. Thank you very much. I think this concludes our discussion. There's no questions from the participants. So then again, I'm very grateful to the speakers. I'm very grateful to the co-chair, so Professor Stefano Guerriero. And I'm also very grateful for the participants and the organizers. I think Extempore did a perfect and excellent job in organizing this. And as said before, our hearts are with Ukraine, and we really hope that peace will come soon, and that this nightmare will end very soon in a positive way. I wish you the very best, and I think now there's a small break, and then we go further with the program using MRI and ultrasound of the pelvic floor. Thank you so much, and all the best.
Thank you.
Thank you.
We had a dream of Sonyo, and Sonyo made it.
Sonyo, pour moi, c'est vraiment la sécurité de l'examen. Voilà. C'est aussi un gain de temps et un gain de concentration, je dirais.
With Sonia, we cover everything from screening to quality control to workflow to improving doctor-patient relationship and to improve the expertise of a doctor in rare situations.
Hello, everyone. It's a pleasure to be back at Extempore. There's always a lot of promise in the Extempore topics that we choose. And I really thank the team at Extempore for making this available to us so easily and at such an inexpensive price. We would spend hundreds of euros and pounds if we were to go to meeting to see this. And here we have access for so many weeks so that we can revise our concepts again and again. And I thank you again for this. We have at the moment 2 speakers for the first topic, which is on MRI of the ovarian masses. And our first speaker is Professor Wouter Freiman. He's a gynecologist, a professor at the Department of Gynecology and Obstetrics at Leuven in Belgium. And I am looking forward to his presentation first. And then we will go over to the second presentation on the same subject from Agnieszka, who is from Krakow in Poland. So over to Professor Wouter Freiman with his presentation.
Hello, everyone. We are very pleased to be here. We will talk about the use of MRI and the assessment of adnexal masses after all the ultrasound topics. We will now cover the potential role of magnetic resonance imaging. I'm very happy to share the virtual floor with Agnieszka Kotlarz, a colleague from Jagiellonian University in Krakow. And we also want to acknowledge Professor van der Kaveye, the radiologist from UZ Leuven, and Dirk Timmerman, as you know, the chair of this morning, for the input in this lecture. So when we talk about the role of MRI in the assessment of adnexal masses, we know that we will, of course, judge the patient clinically, clinical assessment. We will use biomarkers, and we will use ultrasound as a first available tool, ready to be used, a cheap technique and not harmful to the patient. And then you can have several scenarios where the MRI will play a role. So either you have patients with malignant looking adnexal masses with ascites, or complex looking adnexal masses with probably benign features. And there you want to do some staging in order to plan the further management. So you can use CT scan if you want. But we will show that the whole body diffusion weighted imaging will prove to be very useful in staging of malignancies, and it can help you to plan the strategy. So either primary debulking surgery or first neoadjuvant chemotherapy followed with interval debulking surgery. And you can use the combination of the whole body MRI with ultrasound guided biopsy, for instance, to have the tissue diagnosis and plan the patient for systemic treatment. On the other hand, you can have the indeterminate mass on ultrasound. You don't know the diagnosis. So we heard about that next model this morning about the two-step strategy, but sometimes it's still difficult to have a clear diagnosis, and you want some more evidence on the potential malignancy or benign nature of the lesion. And there MRI, so then it's diffusion and perfusion weighted imaging of the pelvis, can play a role to characterize an adnexal mass. And sometimes it can be this additional certainty or this additional argument for benign. So in order to avoid unnecessary surgery. So if you have a lesion that proves to be benign on ultrasound and on MRI, you might follow the patient conservatively instead of exposing the patient to surgical risks. But so ultrasound will always be the first step, and MRI can be used in these additional scenarios. But now I will hand the word to Agnieszka to comment on the use of MRI.
Okay, thank you, Wouter, for the introduction. So I'm here right now from the radiologist side. And as you said, if we got the indeterminate mass, then we go to the characterization. And it's the what is MRI protocol? It's a pelvic MRI scans, sometimes with additional abdominal scans. It's a combination of anatomical sequences and semi-quantitative functional assessment using diffusion-weighted and perfusion MRI. And reporting and characterization have been standardized, first by ADNEX MRI and then by ORAD's MRI schema. The sequences we used are T2 weighted imaging in the transverse and the coronal planes, in contrast to look for fatty lesions such as in teratomas. Then we perform diffusion-weighted imaging and perfusion imaging, and actually very important static sequence as a contrast enhancement and at the end of the study. We have scoring levels from 0 to 5 of ORADS, and ORADS lesion 4 and 5 should be treated either surgically or systematically in oncology centers. And why we made that this functional MRI sequence is more difficult, because we have significantly increased sensitivity and specificity. Both diffusion-weighted imaging and perfusion imaging have increased positive and negative predictive values for characterizing or detecting malignancy. Diffusion-weighted MRI is a cellular marker. It's measure the movement of water protons and how much it's obstructed by the cells. So the more cells we have, the more proton restriction, and it's shown as an orange arrow here. We've got the white dot. It's hypercellular, malignant, and borderline tissue. Surrounding tissue becomes black. Then we look for the perfusion MRI, which measures the vascularization. And how we approach this into clinical practice. If we find indeterminate mass on gynecological ultrasound, we do the study in typical sequences. And there are many features on MRI that are clear or highly predictive that it's benign, less than 5% of risk of malignancy. These are present of blood, as in endometrioma, and the presence of fat, as in teratomas, mature teratomas, or sometimes they are typical morphology. And in the lower line, you see lesions that are either cisadenoma and cisademofibroma. And very important feature is that we call T2 dark and diffusion weighted dark. It's a solid part. You can see it's really hypointense, and that's sign of fibrosis. And then we are almost certainly sure that it's benign lesion, and we don't need to go any further. If we have an intense T2 intermediate lesion or bright diffusion lesion, you need to perfusion. We analyze it with perfusion curves. We have 3 types of curves. We compare the perfusion on the lesion with the perfusion of MRI, myometrum, the low risk type of curve. This is just a flat line. So the myometrial line is the top curve that show the arterial enhancement, and then the flat line is the venous phase. Low intensity is just flat perfusion. Intermediate risk or type 2 has a shoulder showing some arterial enhancement, and this is typical pattern for borderline tumors. Type C or high risk perfusion curve usually associated with invasive cancers. So if we have a defined malignant mass on ultrasound, there is no point on doing ORADS MRI. We don't need to confirm malignancy, but we need to continue with stages. And there are a lot of researches going on in Leuven, and in Leuven Center, they use whole body diffusion weighted MRI to stage a patient with ovarian center. Why is this? In the past, they have compared CT scans with whole body MRI, And in opinion of radiologists here, CT scan alone cannot predict optimal debulking surgery. It's good for initial screening, but it will never help to decide on treatment. And another technique, PET-CT, is a very good technique. It can detect lymph node metastasis, but doesn't detect peritoneal implants. So whole body MRI has two advantages: detects small peritoneal lesions as small as 3 millimeters, and it's not sensitive for inflammatory lesions. So regarding the treatment of ovarian cancer, it all depends on the center. There are 5 operability criteria that are applied in Leuven. That's shown in that table. The report should show the changes with particular focus on these lesions. And now we would like to show you how it works, the cooperation between radiologists and gynecologists. And we would like to show you some cases.
Thank you, Agnieszka. Before the cases, just one slide more on the IOTA MRI study. It's actually an international multi-center prospective study, including patients where ultrasound did not give an exact diagnosis. So these were all patients where the IOTA simple rules had an inclassifiable result. So there was no malignant or benign diagnosis when you used the simple rules. So this is a well-delineated group of indeterminate adnexal masses, and those patients are collected prospectively. So after the ultrasound, there is this diffusion perfusion weighted MRI scan done, and the NexMR score is being calculated. So we have almost 300 patients in the study, and at this moment we have over 200 already completely cleaned, but we're preparing the final analysis of the study to look at the additional value of MRI compared to ultrasound in this more difficult group of adnexal masses. So this is evidence to be followed very soon. So the first case that we would like to present is a patient of 24 years of age, and she had an incidental finding of a right-sided ovarian mass of 7 centimeters, as you can see. At some transections, it looks completely cystic, so completely unilocular cystic, with some low-level echogenicity, so it's not completely dark, the content. And it's noteworthy to see that she had already a surgery in the past, a bilateral cystectomy, 10 years ago for bilateral mucinous cystadenoma. Show you some more images. So if you look at it dynamically, you can see there are some pseudosepta present in the lesion, but also in the wall, there's this annoying structure which looks rather solid tissue. It looks like a solid component, which makes the wall irregular. And it was not mobile upon pushing with the probe. So when you push with the probe, it did not move. When it would move, you know it's a jelly or mucin deposits, but here, or a blood clot, but here it was not moving. So we were not so sure on ultrasound whether we were dealing with a solid component or not in this case. So you see a pseudo septum here, it's incomplete, and then at the base here we can see there's a protrusion, some kind of papillation, as you can see, measuring 16 millimeters in largest diameter. So in case of doubt, solid or not solid, we say it's a solid component. So in ultrasound, we said that this lesion was unilocular solid. There was, however, no clear vascularity inside this component. So we saw some vascularity in the wall of the cyst, but not inside this papillation. So the question is, do we consider this as a benign mucinous cystadenoma, some recurrence, or could it be more? Could this be a borderline tumor? So we called our friends, the radiologists, for help us to differentiate this lesion. So Agnieszka, help us.
Okay, so we scanned the patient. And sometimes when you scan the patient, radiologists could say that it's only to pelvic MRI, it's enough because it's shorter. But you can also ask for the short scan as with abdomen in a rapid protocol, which gives you more information. and view a whole abdominal cavity and allows you to roll out the malignant prosor. And in this case, we see a cystic lesion in the pelvis, and the whole upper abdomen is clear. Everything is dark here, mostly on the diffusion-weighted scan. The lateral coronal fascia is clear. We see only a hyperintensive signal on the left, but it's a physiological signal from the spleen. So after that initial scan, we move to tumor characterization, and here we see only a thin wallet cyst with septa and without any solid deposits. We are still going to check all the criteria. We always look at the lesion with in two projections, coronal and transverse, not to miss anything and any possible even small lesion. So this thin wallet septa was dark on T2, and in contrast enhancement scan, there is no enhancement and everything is dark on diffusion weighted imaging. So in summary, it's ORAT's MRI2, T2 dark. There is no need to go for a perfusion for the lesion, and it's clear that it's benign.
Thank you. So with this information, we know the patient was very young. We planned the patient for a laparoscopic cystectomy, and you can see here the left-sided ovary, and then on the right side you can see the cyst, and like eccentric to the cyst you can see there is the normal ovarian stroma. So we succeeded in doing a laparoscopic cystectomy without any spilling, and luckily the result showed to be a benign mucinous cystadenoma. Second case is a little bit more annoying. So this is a patient that has 50 years of age, and she presented with pain in the right iliac fossa. In the history, she had already a laparoscopy for endometriosis, but it was not so clear what exactly was done during that procedure. And when we looked back in the file of the patient, we could see ultrasound scans of 4 years earlier. And you could already see a unilocular cyst here with ground glass content in the ovary, so suggestive for the presence of an endometrioma. But this is 4 years ago. Today, she's coming with this lesion. She has a cyst which has no clear anechogenic content, so it's more hyperechogenic content. Depending on the gain, you could say low level or ground glass content of the cyst, but then that's not the only issue. So you have in the wall of the cyst, you see that it's not only cystic, you have solid components. There are structures in the wall of the cyst, so originating from the wall of the cyst, protruding inside the cyst cavity, which measure at least 3 millimeters. You have several of them. They are irregular, so these are protrusions of solid tissue. So these are papillations. So the cyst is unilocular, solid, because of the presence of papillations. And we counted more than 10 papillations in this patient. So it was on the right-sided ovary. So the maximal diameter was almost 10 centimeters. And then the size of the largest solid component was about 4 centimeters. Here you can see a 3D reconstruction, a rendering technique, which shows the presence of all of the papillations. In addition, there was also obliteration of the pouch of Douglas, and we had some attraction of the rectosigmoid here, as you can see, towards the right uterosacral ligament, where we could see also a hypoechogenic nodule. But there was no clear transmural invasion in the bowel, but you could see there is endometriosis here attracting the bowel towards the uterosacral ligament. So there were more signs of endometriosis in this patient. When you put on the color Doppler, we saw they were not just blood clots like we see in often in endometriomas. Sometimes in endometriomas you can see blood clots or calcifications in the wall. or debris, but here you could see it's clearly vascularized. So you see that every of these papillations, all of them are vascularized. So you know then it's not just blood there or mucus or calcification. These are real vascularized papillations, so which is more suspicious, as you can see. The CA125 in this patient was 120 kilounits per liter. So of course, in this patient, we were wondering, are we still dealing with a borderline tumor, like seromucinous tumor or an endometrioid? Or is it already an invasive endometrioid or clear cell ovarian cancer? So for this, and to look further on this case, we called again our friends from the radiology department, and Agnieszka will tell you more on the MRI.
Okay, so we perform the MRI in all sequences that are necessary to characterize the lesion, but also to extend to detect lesion throughout the body. And we see that the lesion has multiple integral growth, and it's also restriction in the diffusion. So here is the lesion, and the restriction if in the other sequences. Here we've got the coronal scan of diffusion slice, and it's whole body example that there is no microscopic metastasis. There is no distant metastasis, and importantly, the deposits of endometriosis around the bowel. Don't show up any diffusion imaging. So when we do the assessment, we use the 5 criteria that surgeons use to turn the operability. Obviously, there is no critical site, so we would say this is probably a patient who will be able to go into the upfront debulking.
The patient underwent a staging laparotomy. We performed the hysterectomy, bilateral sublingual with frozen section, omentectomy, peritoneal biopsies, and cytologies. Because of the frozen section that showed a malignant adenocarcinoma, they did also a pelvic and paraortic lymphadenectomy. The outcome of the patient was a FIGO 1C2 because of tumor at the outer surface of the capsule. Endometrioid ovarian cancer, clearly associated with endometriosis. After complete R0 resection, she had adjuvant carbotherapy 3 weekly. We move to case 3, and we will need to speed up a little bit because we will be short in time. This patient was 40 years of age, and she presented with abdominal bloating and pain. She had a large lesion on the left ovary measuring 14 centimeters. You see it's solid, it's irregular solid, so it's not a clear, smooth delineation. You see irregularities. And also the right ovary was enlarged, was measuring almost 6 centimeters. So it was a bilateral solid enlargement of the ovaries, bilateral solid tumors. This is a transabdominal view of the mass, the largest one. And then contralateral, you can also see an enlarged ovary. So there are cystic areas, and the outer surface of the tumor is irregular. Putting on the color Doppler, you can see quite intense vascularity, and very particular in this tumor is, as you can see, some kind of pedicle artery. There's some kind of a lead vessel, one dominant vessel which is splitting in sub-branches, and that is something on ultrasound that always makes us think about a potential secondary metastasis. This has been published before by the group of Antonia Testa. The CA125 in this patient was 862, and the CEA measured 77. So the first question we had on the ultrasound is, of course, we know it's malignant, but could it be a secondary metastasis? And if yes, where is it coming from? So again, it's a turn of the radiologist to answer the question.
On the MRI, we also see the lead vessels, but we see a kind of arborization on T2, which is not consistent with primary ovarian cancer, but it's typical for adenocarcinoma from colon or pancreas. It shows a very distinct feature with the ovarian mass, and but there is another distinct feature that's worrying. Here we've got small triangle into the liver, and its obstruction of the bile duct due to the presence of small tumor. So we have a liver metastasis, and this is not typical site for metastasis from ovarian. So we have pinpoint direction. We need to immediately look for lesion in other organs. In terms of staging, we see the diffuse infiltration and diffuse weighted imaging. And MRI, it's also some lesion in the mesenteric root and the small bowel. Contrast enhanced MRI has some advantages. Here we see angulation and diffuse carcinomatosis. When we look at the implants in ovarian cancer, they should be the same bright as a brain, and they are not. This indicates us that the tumor has a lower cellularity and is mostly like a mucinous tumor. So when we look for the transverse section around the ovarian lesion, we see changes in the colon, and it's most likely a metastatic cancer from the sigmoid colon.
Thank you. And in fact, it was a metastasis from a colorectal cancer, so a Krugenberg tumor, and the patient is under chemotherapy. To conclude on ultrasound and MRI. So ultrasound will always remain the first line choice. It's cheap, it's not harmful, and easily accessible to us as the patient in the gynecological practice. But it's so important to have a good collaboration between the gynecologist and the gyne-oncologist and the radiologist, because there is a role of MRI in additional characterization of indeterminate masses on ultrasound using diffusion-weighted imaging, dynamic contrast enhancement MRI. But in addition, also when there's a problem of malignant tumor, you will use MRI for staging of ovarian cancer using whole body MRI. And in cases where on ultrasound, like, for example, the next model, you have an increased risk of a secondary metastasis, you can use MRI in that case to detect the primary tumor origin using a whole body MRI. So I hope we could convince you that there is a role of MRI next to ultrasound or after ultrasound in some cases. And I would like to thank you for listening. And also I would like to thank Agnieszka, my co-speaker, for this wonderful talk together. Thank you.
Thank you. Thank you, Walter.
Well, we will be back again for a discussion on the previous talk in a few minutes. So I'll request Professor Freumann and Professor Agnieszka to stay on for that. And I will now invite myself, if I may, to give the second special talk today, which is on ultrasound of the pelvic floor. I am from India. I'm a radiologist, but have a background of ultrasound and obstetrics and gynecology. And so here we go. Hello to everyone, and it is indeed a pleasure to be here at the 7th Annual Congress of the Extempore series of ultrasound in obstetrics and gynecology, and my thanks to this organization to make this possible, and a very special thanks to Professor Avishawi and Professor Dirk Timmerman for this invitation to me to actually be here. I will now tell you all about ultrasound of the pelvic floor over the next 25 minutes and try and make an explanation out of what we see here, such as a lesion here seen very close to the urethra, or the fact that you can assess the actual movement of the urinary bladder and the rectum during Valsalva, and the fact that you can do 3D reconstructions to try and get more information. we do understand that one of the most important situations in this whole situation is indeed to be able to put things into a clinical perspective, which means that we must answer the questions that the patient has and that the clinician has. And so I'll take you through imaging techniques, pattern recognition, and wherever required, a quantitative analysis, and also try and explain what images like this look like. This is a 3D reconstruction, what we call a rendering of the pelvic floor. The outer bright area is the levator ani complex. The anterior round portion here is the urethra, and you can actually see one of those tapes getting into it and into the cavity. Right behind that, this is the area of the vagina, and this area here at the back is the rectum, and this is exactly the area that we like to look for when we're making a diagnosis of disease of the pelvic floor. We look for interruptions of the levator ani complex. We look for urethral abnormalities. We look for vaginal abnormalities, and the outline can get altered by a cystocele or an enterocele or a rectocele. And we look for rectal problems, if any. And this would all be in the perspective of what the patient is presenting with. So moving on, we do understand that when we talk about the pelvic floor, there is a huge degree of abnormalities that excuse me, need to be analyzed this way. And apologies, a urinary incontinence is really the most common one, but also recurrent urinary tract infections, persistent lower urinary tract symptoms, fecal incontinence and flatus incontinence, pelvic organ prolapse, and either sexual orgasmic dysfunction. And essentially what we look at always is, of course, situations like this, where we like to look at tapes, or situations like this where we like to make a diagnosis of where the bladder neck turns to go down whenever there is a patient strained by Valsalva or by coughing. The perspective is that there is this wide clinical spectrum. There's a high morbidity and quality of life issues because a lot of these patients will actually be smelling of urine or feces and therefore get cut off from their routine lives by their friends, neighbors, and society in general. But we have established and evolving treatment options which can be offered to improve the quality of life. A lot of these patients are in the second half of their life, most of them postmenopausal and retired, and they can't afford such bad quality of life issues, and therefore we owe it to them to give answers and treatment options that will then improve what happens on a minute-to-minute basis in their existence. And we also understand that although there is a lot of neurosurgical procedures by which you can fix what has gone wrong, such as a prolapse repair with gynae mesh, or a ligament fixation of the sacrospinous with the laparoscopic or an open approach, for the gills with a laparoscopic sling, a posterior defect repair, the institution of transobturator transvaginal tapes, or TVOTs as they're called now, and cystocele repairs and perineoplasties. There is beyond this also the fact that before we do this, we must try and give a simple actual diagnosis with a simple technique. A lot of the times this was done with MRI until recent times, but we do understand that it can be done with ultrasound. And because ultrasound is dynamic, and MRI, of course, is dynamic, but it's not so easy to use in a dynamic phase, ultrasound has actually manifested itself as the best way of doing this. Also because ultrasound answers some very serious questions. What are these questions? Very importantly, there is this question of the method of treatment. So a urethral hypermobility is better handled with a transobturator mid-urethral sling vis-a-vis an intrinsic sphincter deficiency, which is handled with injectable bioagents into the periurethral area. So if we have such a choice of therapeutic options, we must also make sure that we have a diagnosis made for what is the actual anatomical cause of the patient's symptoms so that it can be then managed appropriately. Because the other question is even more serious, because when you do repair these and you have mesh and foreign bodies in place, it can result in dyspareunia, which can sometimes be the patient's original problem, or the fact that urinary incontinence separated the couple apart. And then you can't have a dyspareunia either for the female or for the male, and therefore you have to be careful in answering these questions correctly. But perhaps really the most relevant example is the fact that there was a phase that we went through where there was a failure rate of procedures and complications of surgery, so much so that the FDA of the United States of America actually said that we must stop these procedures in 2011. There was also the outburst, of course, of public as well as of the legal profession against the medical profession, but the actual situation in America was very sensible. The AGL, the American Association of Gynecological Laparoscopists, responded to the FDA patient safety, saying that it refers only to the use of surgical mesh for pelvic organ prolapse and not for the rest of the procedures, and therefore these techniques have been restored to make sure that the patient gets advantage of these techniques. Even for the use of surgical mesh, we've come a long way since all of this happened about a decade ago, and therefore we now understand that a diagnosis is central to how we're going to follow up these patients afterwards. And I will show you how ultrasound benefits us, because we have to answer the patient's question. The patient's question is very simple. The patient wants to know what has happened to me, why is this happening, what does it imply for my future existence, and what best can be done about this. And let's go about trying to understand what these questions mean and how they can be answered. Because really, it's not just about the surgical procedures I showed you before and choosing the right surgical procedure, but the fact that a lot of this can be overcome by either pelvic floor exercises or high protein diets. We used to use a lot of the antidepressive drug duloxetine, but it went into disrepute. But a lot of the newer ones have come back and, excuse me, and can be used for the same reason. You can also do lifestyle modifications, such as when can water be had and when should it be stopped during the day so that the nights are more comfortable. The fact that hormones can improve blood supply to the perineum and therefore improve muscles. And then, of course, surgery as a last option. And so we're going to answer these. The conventional protocol to answer these questions was, of course, a clinical examination of the perineum and a pervaginal examination, followed by a general examination of the patient, which then used to go on to a urine analysis and appropriate blood work. In the older protocol, there used to be this crazy system of all kinds of investigations, including a bead chain cystourethropy, uroflowmetry, urethral pressure profilometry, then a dynamic MRI, and then a cystoscopy. This has changed thanks to ultrasound, and what is now used is a conventional radiology, depending on whether we need these or not, and then we move on straight to an ultrasound or an MRI, depending on personal preference, and ultrasound being easier to do, ultrasound being more easily reproducible, and of course less cost. It seems to be the answer rather than the question. We, of course, understand that there is a newer protocol where on the ultrasound, after looking at your conventional KUB, which is a kidney, urinary bladder, and pelvic ultrasound, we look for post-void residue after the patient has passed urine, and then go on to assess the pelvic floor by placing the transducer at the introitus. It's got different names. Some people call it introital ultrasound, some people call it translabral ultrasound, and some people call it quite simply pelvic floor ultrasound. But really what we do is a combination of 2D, 3D, and real-time 3D studies, which are called 4D studies, combine them with power Doppler where necessary, and then move on to decide what is the best way to handle these. The appearance on 2D of the urethra is something that you need to understand before we go on to study this. So here you see a full urinary bladder, and in a transverse approach, this would be the urethra. If you were to look at the urinary bladder from an anterior to posterior direction along its long axis, the urethra appears at the base and comes anteriorly as it moves towards the pelvic floor. And so this is very important to understand, because if there is an opening of the urethra when the patient coughs, then you know that that straight away is a stress urinary incontinence. And if it opens when the patient is neither straining nor coughing, then that, of course, is a situation where you have a different type of incontinence, which is then handled differently, because you have the various types of incontinence with different types of treatments. You also have transient and permanent incontinence, and then these have to be investigated by this way to make sure what happens to the urethra and what needs to be done about it. You can also cause a strain by asking the patient to actually do a Valsalva maneuver, which means blowing up her cheeks, blowing up the tummy, and applying pressure below, and then watch what happens to the bladder and the bladder neck. And you can see how far below the perineal floor the bladder actually goes, demonstrating thereby that this is indeed a bladder that is going far too down and is a large cystocele. It's also important to realize that in this whole situation, we like to understand the bladder not only before and after passing urine and demonstrating what happens to the bladder neck, but also to see whether there's any trabeculation of the bladder, any post-maturation residue, and the overall wall of the urinary bladder, as well as any masses in the pelvis. So in addition to this, if there is any bladder pathology, such as bladder calculi or round body, then you have to make a note of these and, of course, look for bladder and urethral diverticuli. And I will show you some diverticuli as we go along. The other thing that one has to look for is whether there is a mass next to the urethra or urinary bladder, whether there are anterior wall uterine fibroids, and, of course, the discordant funneling of the proximal urethra in relation to the patient actually showing incontinence. So it's an interactive process as well, where you expect the patient to let you know that, yes, oh, I passed urine, and it coincides with the opening of the urethra, or that the patient was actually straining. You saw it on the screen and you said, did you feel the wetness of your underclothing when you did this? Or the actual observation by you or your technician on whether there was a loss of urine or not. So it's a real-time investigation that you have to do, because you will document the type of incontinence and, of course, like I said, estimate associated causes within the pelvic cavity. The information, of course, is to be able to identify the type of incontinence when it is incontinence. And each one of these, like I've said before, is to push, and see what happens to the bladder and see whether it goes down or not, like here. Now, please do remember that you have to educate the patient in trying to do this pushing, because when she does it for the first time, she perhaps doesn't know what she is doing. In fact, she may not be applying strain at all. And if she doesn't apply strain, you'll miss out on findings. So this bladder going really all the way down would be missed completely. And the same thing would be on what happens to this patient here. This is what is known as the anorectal angle. So this is the pelvic floor. This is the urethra. This is the symphysis pubis. This is the anal canal. This is the anorectal angle, and it's very well defined in almost every patient, except the most flatulent. And then you observe what happens to the rectal area, the anorectal angle, and of course the bladder neck as the patient strains appropriately. So that becomes a very important thing, to make sure that your patient is actually applying that strain. Otherwise, you could underdiagnose or overdiagnose a particular situation. How do we orient the transducer? Well, you keep it in the pelvic floor so that you get a view of the symphysis pubis, behind which is the urethra and the bladder base, behind which is the vagina, and care has to be taken that the beam is wide enough to not stop here as in the first illustration. We do understand that the anorectal angle is a posterior structure, and the box, particularly when you do 3D, must incorporate the symphysis pubis, the urethra, the vagina, and at the back, the anorectal angle, all the way back to the bone at the back here, the sacrum, so that when you reconstruct, you can actually make out all these structures from front to back. So if that is done correctly, then yes, you would be observing both on MRI and on ultrasound the symphysis pubis in front, and this is in real time, the urethra here, the vagina here, and the anorectal angle. Let's see it again here with the dotted lines. Right at the back, you can see the anorectal angle, and in this particular patient, it's a very straightened out anorectal angle. Remember that if you increase the depth or go too far in, you would be able to see the uterus at the back in the image in this particular area. What about MRI? Well, you can see these things very well, but the contrast resolution on modern ultrasound equipment is far better than that on MRI, and the ability to be able to actually perform all of this is far better on the MRI. So in this situation, then the ultrasound is preferred, particularly 3D ultrasound, because it will show you these landmarks as I've shown you before, which is that you have a line drawn from the symphysis pubis all the way back, so that then you see the vagina in the middle, the urethra anteriorly, and the actual rectum posteriorly, and the bright area all around is actually the levator ani complex. Do we need to know the muscles individually? And the answer is no, because when it comes to repair, we repair all of that together and not the individual muscle fibers. It's a pelvic floor repair. And therefore, you don't need to know the individual groups of muscles as they lie in the pelvic floor. So there are two ways of doing this. One is by using a transabdominal transducer, and the other is by using a transvaginal transducer. In the initial phase, when you're learning the technique, you do realize that the transabdominal transducer is perhaps easier, but the contrast resolution is not as fabulous as a transvaginal transducer, and particularly when you use a slice thickness, a technique called VCI, which is all preset with the equipment, then you get more and more used to the transvaginal transducer. And then you see how nicely then, compared to the previous image I showed you, you can see the urethra anteriorly, the vagina in between, the rectum at the back, and a bright area all around, a diamond shape, so to say, of the levator ani complex of muscles. Now, the anatomical considerations can be demonstrated as a single 3D sweep, or you can see them in real time and then observe the same things depending on what you want to diagnose. Remember that the newer rendering engines would be able to render the levator ani complex more clearly. Also, the contrast resolution around the rectum is far better, and therefore you can see it. You have to have your settings correctly so that again you can see, as you see here, the urethra anteriorly, the rectum at the back, and the vagina in between. And like I mentioned before, the actual individual muscle groups do not need to be assessed because repair does not address the individual muscle groups. You can go on to another 3D technique where you realize and demonstrate that the pelvic floor is not just something about being a single section, but something from below upwards, and you need to then demonstrate each section. So when you go to the higher sections, you will see the rectum and the sigmoid at the back. The true middle section would be this one, demonstrating the entire levator ani complex with the urethra and the rectum. And you can use different tints to see better. And you will also realize that in some individuals, the levator ani complex is far more echogenic, and in some with atrophy of the muscles, you may not find it so echogenic. What you have to make sure is that you're actually slicing through that area, so when you don't see it, it's not a technical artifact, it's a true situation of those particular muscles, and you can assess it by looking at the topogram in the TUI, as we call it, which means the lines are drawn across at a fixed distance, and you can make this distance vary, and obviously it should be located within the pelvic floor and not in the area of the bladder, which is far more cephalad compared to where we're trying to look for pelvic floor disorders. The other thing that you have to realize is that all the newer equipment has far better contrast resolution, that you can actually draw these lines across not just as straight lines parallel to the floor, but you can tilt these lines so that you can actually see all the structures better. So in this technique called OmniView, where you draw the line wherever you want, you can make sure that you're invariably including the symphysis pubis, the lower end of the urethra or the upper end, the vaginal area and the anorectal area along with the anorectal angle, and then you pick up the same structures. The vagina can look very differently structured. I will include that in the next few slides. The important thing to realize is that you can automate all of this, fix a near plane and a far plane, and keep studying it here as you go along so that you can see dynamically from above to below what happens to the anatomy. So the urethra would look quite different at its lower end, the vagina would look different, and the rectum would look different depending on where you slice through. So all this has to be done in real time, and you have to then realize that yes, real time is truly the way to go. This is also known as translation cine, and it's something that you can set automatically into the machine. It takes only a few seconds. Now, you can quantify a lot of this, and one of the main things that is often quantified is, of course, an angle that the urethra makes with the base of the bladder, but also the total size of the introitus here. And then there are actual measurements for ballooning, depending on whether it's 25 to 30 cc's or between 30, 35 and more than that. And then you can assess whether that is the reason, and therefore the degree of repair of the pelvic floor that is required. Please do remember that there is a variation in the appearance of the vagina, and the vagina can appear very collapsed and U-shaped, or it can appear very large and H-shaped, and this has nothing to do with whether there is a sexual activity or deliveries. It's got to do with the basic congenital structure of the vagina, and therefore it is not unusual to have a vagina that is a plump-looking vagina in this area, sandwiched between the urethra and the rectum. Note again the levator ani complex, which in this patient is particularly full because she is extremely athletic and very particular about her diet and exercise. The technique when you use the transabdominal transducer is again a 3D transducer covered by a sleeve, and you put gel on the outside and you place this in the front. You have to have used warm gel because otherwise there would be puckering of the labia, and then move on to a supine position, which changes to semi-reclining to help the patient strain. Standing is really not ideal because that becomes very, very difficult to handle. The long axis of the transducer has to be along the long axis of the patient's orientation, and then you can move the transducer whichever way you want, in and out, up and down, or sideways, and demonstrate the urethra, the bladder, the periurethral tissues, the endopelvic fascia, as the levator ani is called, the vagina, and the rectum, as I have shown you. Now, please also understand that at the same time, you will make the patient strain and look for descent of the urethra and the bladder neck. You will also ask her to clench the pelvic floor and see how reactive is the pelvic floor, and then move on to do all of this in Valsalva and in coughing. So unless you go through all of that, your study is not complete, and it can be a little tricky to have contact all the time in this area, but this is the way to go about it. So here you have, again, the patient trying to strain. This is the initial part of the study. She hasn't learned how to push as yet. You educate her for a few minutes, and then she will show you very nicely. So you have symphysis pubis, urethra, vagina, and this is the rectum and the anal canal. So this is the anorectal angle. Now, it is typical to suggest that the bladder should not be completely empty, but it has never been defined on how full is a full bladder. Most people at that age will not be able to have 300 ml of urine in their bladder, but really 150, 110 is quite enough. And then you try and demonstrate all these things with that amount. Can you make out bladder descent? Well, this was the older way of seeing it. The newer ways, as I've shown you, you ask the patient to strain, you look at the morphology of the bladder neck and assess what it was at rest, shown by this dotted line here, and how much at maximum strain, shown by this. And this measurement is a much better way of assessing bladder neck descent than by the transabdominal route. And here another example of the same thing, where you assess how much the bladder neck moves down almost out of the patient's body to go well below the symphysis pubis as you see here, and then that would be bladder neck descent, which in this case was 17 millimeters. When you have trauma, you find bits of that echogenic outer area missing, and here is a unilateral avulsion. And when you use a multi-slice, the TY, you will find that you can demonstrate it even better at multiple levels. You can also find it bilateral. This is by a abdominal transducer, and I prefer to use transvaginal, because look at the anatomy here, far better than before. The urethra in front, one tear here on the left side, one tear here on the right side, and the entire rectum here. And you can see the rectal mucosa and layers so beautifully as you see here, both as a single 3D image and as a multi-slice image, because like I said, the entire pelvic floor goes over an extent of a few millimeters and is not just one slice thick. We can also find that there are parts that are interrupted in the levator ani, lots of fibers seen anteriorly, not much posteriorly, and a complete interruption behind the rectum. As long as your green line on the 3D reconstruction is placed correctly, you will then realize that, oh, this is missing. It could be either due to a tear in the rectum or a complete atrophy, and the way to see it really is to feel the tone on a clinical examination. Sometimes you get all the landmarks missing, like you see here. There is no anterior landmark, no posterior landmark, and again the possibilities are third-degree perineal lacerations of a bad or a difficult delivery, or that with atrophy everything has just disappeared, and then you try and figure out from the patient's history and the feel of the muscle tone in the pelvic base on which of these is the possible cause. Here again is the same example. Here you do see everything all around as the levator ani, but there is no hyperechogenicity, and then this would be, of course, very clear diagnosis of atrophy rather than a diagnosis of a laceration of the pelvic floor during delivery. There has been an attempt on 3D to identify cystoceles, but that's difficult to do because irregularity of the outline could mean that your plane is not right or that you have a cystocele. So it's nice to assess cystoceles in 2D rather than on 3D, and exactly the same thing applies for enteroceles and rectal seals. If you have a hodgepodge of all the landmarks, then you know something is wrong, but the true diagnosis will be made on a 2D and a dynamic 2D and not on a 3D. Can tapes be seen? And the answer is yes. Here, for instance, is a normal tape. This tape is too tight and too circular, and this tape has almost stopped functioning on the left side, as you see here. Some more examples of tapes here. You see that this tape is, again, a good tape. This one is too tight. This one is broken on the right side, and this one is a fractured tape that seems to have broken through completely and would therefore result in trouble and a need for a further repair. Sometimes these are very dramatic because they appear very echogenic, and you can see them without the reconstruction, but it's just so far easier to see them with a good reconstruction with the VCI and not just a simple reconstruction without the VCI. VCI refers to volume contrast imaging, and the equipment is preset to put together several sections to get the clarity of this kind of an image you see in the bottom right. There are newer approaches where we don't need new equipment or additional equipment to show the anal sphincter. All we do is to rearrange our lines in the topogram, and we can make out the entire anal sphincter in a longitudinal section and in an axial section so clearly that we don't need dedicated equipment to actually show this. So with the help of 3D, you can actually manage on standard equipment and don't need equipment that does only this work, which is so important in the cost considerations of society today. You can see urethral lesions. So in the base, for instance, you see here a urethra and an eccentric solid hypoechoic lesion, cystic lesion, and then you realize, well, here it is in relation to the urethra, a cystic portion here, mixed echogenicity here, and then you say, okay, when I redo my multiple sections, I know that this, from its appearance, is an infected urethral diverticulum, the differential diagnosis is an epidermoid in this region. How about automation? Well, AI is there everywhere today, and there seems to be a lot of work on AI in these equipments that demonstrate the pelvic floor. And what is automatically done is to do a plane alignment in Valsalva and then an automated measurement of the levator hiatus. Let me show you some close-ups. So this particular line here seems to work automatically to go up and down and remain in the pelvic floor and give you the best demonstration. So you don't have to make an effort, and the equipment does it automatically. And it does this for you in the standard plane, up and down and wherever you want, so that then you can study it either with a single rendering or a multi-slice rendering. So let's see what it looks like. So here is the actual line, the VCI line and the thickness, and it has automatically put itself into where you see the best possible outline of the levator ani complex. So to answer the first question, we do ultrasound because it can be done well if you know how to do it well. It is now proven to be reliable and frequently superior to other methods, which are clinical or MRI, and because it proves patient outcomes. And thank you so much for your attention. So there we are, two very interesting talks, and we have some questions that have come in into our chat box. And the first question here is for Agnieszka, and the question here is that in some groups all over the world, after an ultrasound scan, there is a fast tracking to a PET CT instead, presuming that this will give us a much better idea of staging of disease, and to skip MRI as a characterization method. How justified is this?
And so, as also gynecologist, I must say it also depends of the center. If you've got very experienced radiologists in CT scans, it's of course it's the best method. But the whole body MRI that used in Leuven Center, it's quite new methods. There is not still in a lot of centers approval of that or never used that technique. But as we show in our presentation, it's more sensitivity and specificity, and we can also fusion the whole body MRI with CT technique, and we can also predict the operability in ovarian masses, and also we can assess the operability after the new adjuvant chemotherapy. So I think that there is also need a multi-center study of that we plan right now, but I think in the near future it will be very good technique to predict and also to use in the clinics.
Thank you very much for that. And are these done on a 1.5 Tesla or a 3 Tesla or any special?
It's both. It depends of the unit, but 1.5 Tesla is also fine for use. And it's not only in ovarian cancer, it's used for the in some prophylactic, like people with neurofibromatosis, with some inherited disease. They also use it in the colon cancer, breast lobular cancer. So it's very good technique.
Yes, thank you very much. And that was a beautiful series of 3 cases you showed us, which highlighted all the techniques and told us how beautifully you can take the patient from an approximate diagnosis to surgically best diagnosis with really good outcomes if you handle them correctly. Thank you so much for your talk. We move on. We move on to some of the other questions, and these are from me. And the first was a very interesting discussion on whether tapes are still used in some parts of the world. And this again is depending on the type of practice. In India, for instance, we use a lot of tapes because we have a lot of incontinence. We do understand that our patients who are on vegetarian diets are protein deficient and therefore have much more urinary incontinence than otherwise, especially urge incontinence and certainly also stress urinary incontinence. And so we have a large practice of using tapes. There was another question on, can we demonstrate an enterocele from a plain rectocele on dynamic floor ultrasound, and can we also then differentiate a rectal intussusception? So yes, the answer is yes, and we do it routinely. The intussusception in the rectal area is not the dramatic one that happens in the small bowel. It's an intermittent one, and the more the patient tries to pass a stool or flatus, the more difficult it gets, and that's where we have a suspicion of rectal intussusception. And this is done as part of the 2D study, where we check our anorectal angle. We make sure that the debris within the rectum is minimal, and if it is not, then we ask the patient to use a suppository and come back after passing a stool. We don't do it after an enema because we feel that the liquid of an enema doesn't work. And then you can actually tell whether it's small bowel, because that'll be prolapsing between the vagina and the rectum, or it's a plain rectocele where the rectum comes down on straining. And then you can actually demonstrate that the upper part of the rectum comes down and you find a 4-layer of bowel wall between the beginning part of the anal canal and the last part of the rectum. So it is possible to differentiate between the rectal intussusception, enterocele, and a plain rectocele. We also have one more question on, and this is again for Professor Agnieszka. How comfortable are clinicians with just abbreviations such as ORAD's MRI? If you were to give an alphabetical description at the end in your report, do they find it easy to understand, or do you have to give an elaborate description also in your reports?
In our unit, we just put it like ORADS 1, 3, 4. But as from the other side, when we check, to be honest, we check for the results and guidelines. Of course, there is some gap in the ORADS 4, and it's we are not happy at all that it's only prediction in 50%. So I think that further further research should be also going on in that field. But as a clinician, we usually describe the lesion not as radiological features, and but only the results, also to suggest what the type is that for the predict histopathological result, not this description in the radiological. What is because for a clinician it's not readable. What is like T2 sequences? What is the enhanced contrast? So it's doesn't useful. It's waste our time and their time. We only suggest the results, and I think it's the best method to report.
Thank you. And with that, we come to the end of our discussion time. My special thanks to Dr. Wouter Freumann and to Professor Agnieszka to be here with us today and show us so beautifully the role of MRI in adnexal masses. And I quite enjoyed viewing my own talk on the pelvic floor. Thank you very much.
Thank you very much.
Welcome to a special session on some very interesting topics in gynecology at our 7th Annual Congress at Extempore. And our first speaker in this session is going to be Professor Igal Wollman, Associate Professor at Tel Aviv Medical School of the Tel Aviv University and a Senior Consultant at the Ultrasound Unit of the Lis Maternity Hospital, Tel Aviv. And I'm so looking forward to his presentation on scar assessment before pregnancy. So over to you, Professor Wollman, for your presentation.
Now.
Okay, so good afternoon, and thank you for having invited me to speak about this interesting subject. I will talk about the uterine scar dehiscence, which is also called ismotzele or the niche. So I was first aware about this a few years back. You can see maybe 11 years back when I had a patient who came to my office during 22nd weeks of pregnancy. And I actually saw that there is no, between the bladder and the uterus, there is nearly a hole. And I hospitalized that patient, and we held her until 30 weeks of pregnancy, until she had pain. You see, this is transvaginal. You can see that there is actually just the fascia. That's it. And this is in still pictures. And actually, you see in the operation, you see that once you open the peritoneum, you can see the amniotic sac. And actually, the uterus is totally dehiscent. And the head is actually halfway out with the amniotic sac. And you can see that actually the whole scar is dehiscent. So when we talk about the niche, ismotzele or uterine scar dehiscence, we're talking actually about the area where the surgical incision was made. And you know that actually that C-section is the most common operation in obstetrics in all over the world, with rising incidence all over in most countries. And in several ultrasound studies, defects in the hysterotomy scar after C-section and C-delivery have been shown to be common in non-pregnant patients. The clinical importance of larger scar defects diagnosed by ultrasonography in non-pregnant patients is not yet known until today, but many authors contemplate that larger scar defects are likely to reflect incomplete healing of the scar. So the first to describe it was Anna Monteagudo with Ilan Timor-Trich, and they defined the niche was defined as a triangular anechoic filling defect in the anterior wall of the uterus between the corpus and the cervix immediately under the bladder recess. Renard actually presented a study. They were treating patients, infertile patients, and they saw that they encountered an unexpected image of a very deep niche after C-section in 2 patients undergoing fertility investigation, and they decided to evaluate the prevalence. They wanted to investigate the frequency of images suggesting the existence of dehiscence at the site of the uterine scar after C-section. And they evaluated by saline contrast sonohysterography, which was performed at a minimum of 3 months following C-section. The thickness of the residual myometrium, the thickness of the myometrium bordering the scar, and the depth of the filling defect in the scar were recorded in each case. A dehiscence was defined as a niche whose depth was at least 80% of the anterior myometrium. Actually a large one. And this is, you can see the niche here, it's very clear. And you can measure the rate or how much is it, how much does it take from the width of the whole wall. After 33 patients, 17 had a small niche and 2 a large one. However, the exact clinical significance that one should attribute to a deep niche is unknown, since a link between the thickness of the uterine scar and its strength has not been evaluated. So you can see that we have many different shapes of the niche. And the most common is this one, and triangular one is less common. Less even common is this kind of sign, and sometimes it's actually very difficult to see it, and you have to evaluate it. But no correlation between the number of C-section deliveries, the depth or shape of the niche was established. And you can see this patient that actually was referred to us to evaluation of the niche, and once you put in a bit of saline, you can see that before that, it seems that there is actually a very small niche, but you can see that the wall is actually gone, and you can measure the niche and evaluate it with a bit of saline. A nice article in just a year ago was published about the definition and sonographic reporting system for C-section scar pregnancy in early gestation, the modified Delphi method. I will not get into it, but I will show you that you can evaluate the niche by 3D ultrasound. You can look at the width or the thickness of the wall, okay? Again, you can measure it, and you can give these results to the surgeon if you decide that you want to treat this patient by surgery. So what would be the clinical significance of a niche? First of all, abnormal uterine bleeding, infertility, pain, and a big question, is it correlated to rupture of the uterus? So there are a lot of articles that are talking about intermenstrual spotting. You can find them all over. And if we take the Maurice et al., they looked at a review of pathology specimens of patients operated, and they saw widening of the lower segment, congested endometrium above the scar, polyps in the scar, capillary dilatation, and adenomyosis confined to the scar. You see that postmenstrual spotting happens to up to 76% of patients with cesarean section delivery, and you have a larger amount of patients with PMS with wider defects. So what would be the mechanism of bleeding? It is speculated that the lack of coordinated muscle contractions around the C-section scar, the niche allows the collection of menstrual debris into the niche, and subsequently the debris leaches out during and after the menstruations, once the menstruation is over, and it becomes intermenstrual. In some parts of the world, it's a problem because, for instance, in Orthodox Jews, they are prohibited for performing sexual intercourse at least 1 week after the menstruation is over. And if they are spotting during the months, they are unable to have intercourse. So this can constitute a very big problem. Now, you know that intermenstrual bleeding is 3 times more common in patients in the niche group than not in the niche group. Infertility was correlated to the niche, and Gubini checked 41 consecutive patients with cesarean section delivery and secondary infertility. After 2 years, all of them became patients, but there was a very high percentage of patients that needed fertility treatments, and you have an anecdotal series of success in IVF after repeated failures and correction of a large niche. Mechanism again, blood or mucus in the niche could affect cervical mucus, sperm transport can be affected, the implantation can be affected, and the cause of a chronic inflammatory state, we can impede implantation. Another complication can be pregnancy in the niche, and this is a case that was referred to us with the diagnosis of ectopic pregnancy, because no pregnancy was shown in the uterus, but once you scan the whole uterus and you move to the cervix, you can see that actually you have in the niche a pregnancy, you can see the yolk sac, and you can see the fetus. So this is another complication. Pain, you see the paper of Wang that showed that 53% of patients with C-section delivery had dysmenorrhea, and 40% with C-section delivery had chronic pelvic pain, can be explained by maybe lymphocytic infiltration or anatomical distortion. So we go back to the first article that we talked about of Reynard, and the last question remaining, as they stipulated, was, is it safe for a woman whom a dehiscence has been found to become pregnant? So actually, Lil Valentine and Vikarova tried to answer these questions from Malmö in Sweden, and they wanted to estimate the association between the appearance of C-section hysterotomy scar, a transvaginal ultrasound examination of non-pregnant patients, and the outcome of subsequent pregnancies and deliveries. Again, this was the definition of the niche. A scar defect was defined as a large, at saline contrast sonohysterography. The thickness of the remaining myometrium over the defect was no larger than 2.5 millimeter. Again, you remember, it's very easy to measure. You don't need a 3D picture for that. You can do it in 2D ultrasound transvaginal very clearly. And a scar defect was defined as large at unenhanced ultrasound examination if the thickness of the remaining myometrium over the defect was no larger than 2.2 millimeter. Again, the dehiscence was defined as subperitoneal separation of the uterine scan in the lower uterine segment with the chorioamniotic membrane visible through the peritoneum, as I showed you in the brief film from before. And the uterine rupture was defined as a complete separation of the uterine scar with communication between the uterine and abdominal cavities. They had 156 patients with 99 pregnancy and 65 deliveries. At the first repeated C-section delivery after the ultrasound examination, 5.3%, 1 out of 19 of the women with an intact scar or a small scar defected uterine dehiscence, while 3 out of 7 of those with large defect had dehiscence. Odds ratio was 11.8 with 95 confidence interval. They state that the results point toward a likely association between large defects in the hysterotomy scar after C-section delivery detected by transvaginal sonography in non-pregnant patients and uterine rupture or dehiscence in the subsequent pregnancy. So the prevalence of scar dehiscence, we know that in the series of Raynaud was 6%, which is much larger than the reported risk of uterine rupture. The risk of rupture before the onset of labor is much lower, is 1.6 in 1,000 consecutively. They consider that the systematic correction of dehiscence before a pregnancy is probably not indicated. Nevertheless, since the risk of rupture is at greatest during labor, they also suggest performing an elective C-section before the onset of labor in this patient. So, to conclude, in non-pregnant patients, you can reserve to conservative treatment. It can be done hysteroscopically if the wall is thick, more than 3 millimeters, and if it's a very large niche and you want to repair it, if the wall is less than 2.2 or less than 2 millimeter, and you can see a very large defect, you can try to repair it by laparoscopy. You have to tell the patient that it's actually, they have signed that they enter, actually, it's an experimental, in an experimental phase, because we have no absolute proof that actually if you have a large niche, they are in danger. But if we would do it if they fail to conceive in more than a year, having fertility treatments, it's been suggested to them. And if you see a large, very large niche with actually you see that there is no wall at all, we would suggest to repair it. I would never suggest normal delivery, even if the niche has been repaired, and we always resort to an elective C-section. And that's it, actually. Thank you.
Thank you. Thank you very much, Professor. Welcome back again. And we are lucky today to have with us Professor Bernard Benoit from the south of France. He's been working recently at the Princess Grace Hospital in Monaco and has superannuated from there. In ultrasound circles, he's known as the Rembrandt, the Picasso, everything rolled into one, a true artist whom everybody wishes to reach that level during their professional level. And it is indeed a pleasure to be able to listen to him today, telling us about Mullerian abnormalities. So over to you, Bernard Benoit, for your masterpiece, which I know will be a masterpiece as always.
So, congenital Mullerian malformation, what is the role and what we can expect from 3D ultrasound in diagnostic? First of all, what we can expect from 3D in gynae. When we are using 3D, it's possible to have the complete volume of the uterus, but without the ovary, because it's too wide with the ovary. And from this volume, it's possible to do first the C-plane. That means it's possible to obtain this view of the uterine cavity. You have exactly the shape of the uterine cavity. We can use it also for the pelvic floor, count and measurement of follicle if you are using the Sono AVC software. And we can do 3D rendering of ovarian mass. And 3D color Doppler, that means we can do a kind of angiography. But today, for my lecture, I will speak only of the C-plane, how to do it, how to obtain this coronal view of the uterus. First, I I never use the abdominal probe because the quality is really better with the transvaginal probe. I have to use abdominal probe only when the transvaginal approach is not possible, and especially in younger children. When you use abdominal probe, you need a full bladder to push all the intestine far from the uterus. And this was one case with empty bladder, and the quality was not so bad, but it was a thin woman with no intestine in front of the uterus. And here what you can see is this is a scar of a previous C-section. When I do my transvaginal examination, I always put the probes, that means this is the extremity of the probe, and the probe is coming from below, here. And the fundus on the screen is on the right side of the screen, and the cervix is on the left side of the screen. And this is for a normal uterus, anteverted uterus. And this is the bladder. That means if I got this kind of view, this kind of picture in the same position, that means the uterus is retroverted. So I know when the uterus is anteverted or retroverted. But this is my way to use it. But I know that there are different methods. Some people, some doctors, sonographer prefer to use this one. That means it's quite the same. The probe is coming from below here. And but the fundus is on the left side of the screen, and here two cases with the probe is coming from below, from above, here and here, and the fundus is here on the left and here on the right. This is not so important, the position of on the screen, but what you have to do, it's always do the same. If you are always working with this method, don't change, always use this method. But you have to know where is the bladder, and it's why it's better on the screen, if it's possible, to show a part of the bladder, because after it will be possible to know if it is anteversed uterus or retroversed uterus. And when we do our examination, this is our guideline in France. We have to do a sagittal view of the uterus with endometrium. We have to do an axial view, also with the endometrium in the middle, and for both ovary we have to do the largest section and with follicles, and if there is a corpus luteum, to show the corpus luteum. And the measurement we have to do is the length, the complete length of the uterus, that means from the fundus to the external part of the cervix. You can do it with a curve, this is more accurate, but if you cannot do it on your system, just do two lines and you just add the value of the two lines. We have to do also the thickness of the uterus and the width of the uterus, and the measurement, the thickness of the endometrium. And for the ovary, the two diameter. And how to obtain this coronal view of the uterine cavity? That means with 3D. The first step is to start with 2D, to put the probe in the correct position, and after you have to start the acquisition. When you think it's perfect, you just have to press on one button, and you will see now we press, and this is the automatic sweep. It will take about 5 seconds. And after, it's possible to work with the volumes. That means here, you just have to move this dot here. You rotate around the Z axis, and now around the vertical axis. And this is a view with multiplanar. But when you use this kind of a view with multiplanar, it's exactly the same if you draw a line, a flat plane inside the uterus, and you cut with a line. But in this case, it's nice for the uterine shape of the uterine cavity, but only this part. If you try to look at the cervix here, this is not the cervix, because if you can see the section here, this is completely outside, the cervix is in this part. So for this, what you have to use is to use a polyline, and with a polyline, you just have to draw a curved line here, all along the uterine cavity, that means the endometrium, and you will see now how it's work, and you obtain this nice view of the complete uterus, but also with the cervix. And in this case, what you can see, it was a small polyp inside the cervix. And all this picture, you can obtain it from 3D ultrasound. And here you have a small fibroma, also here a fibroma inside the uterine cavity, and here two intrauterine device, and this is perfect for the intrauterine device because you can know exactly what is the position of this device. But you have to avoid the beginning of menstrual cycles. That means, because why? Because the endometrium is really thin. If you have a thin endometrium, you cannot obtain such a picture. It's not possible. You always have to do it. The best is to do it from day 10 to day 28. And the best for the contrast between the endometrium and the myometrium, it's to do it just before the menstruation, because at that point the endometrium is really clear, it's quite nearly white, and the contrast with the myometrium and the endometrium is high. But in some situations, especially when you want to see inside the uterine cavity, and if the endometrium is too thin, you can use hysterosonography. That means you have to put some fluid inside the uterine cavity. In this case, it was a polyp here and here. And now you can see here the congenital anomalies that you can find. This is a class U0, that means it's a normal uterus with a usual shape. Dysmorphic uterus, and especially it's a hypoplastic uterus. Septated uterus with a septum inside. Bicorporeal uterus, bicornuate, and hemiuterus. So you have different class of malformation, and this is what I use. And you can see here, when you do the examination, if you have a septated uterus, you have to tell, okay, it's a septated uterus, is it partial, is it complete, and after you look at the cervix to tell if there is a normal cervix, septated cervix, double normal cervix, and also same for the vagina. And after, it's possible to give exactly the diagnostic. But the main problem is to do the differentiation between the septated uterus here and the bicorporal uterus. It's not so easy, and for this you have to look at the shape of the uterine cavity here. So this is really benefit of 3D. You have to look at the cervix, and also you have to look at the fundus to know if there is an indentation of the fundus or not. You have many methods to do the diagnostic between septated and bicornuate uterus. This is one of these methods from Troiano and McCarthy. What you have to do, you have to draw a line between the two ostia. That means this is the intercornual line, and from here you have to do this measurement, and if it's more than 5 millimeters, that means it's a septated uterus. So this one is a bicornuate uterus, and this one too. Now we will use a 3D, and you will see how to obtain the coronal view in case of congenital anomalies. This is first we start with 2D. When you do a 2D, you always have to start with a sagittal view to move from one side to the other side, and after you rotate the probe to obtain the axial view. And in this case you can tell, okay, there is anomalies, but I don't know exactly what kind of malformation is it. So you have to switch to 3D ultrasound, and you draw the line with polyline on the uterine cavity until the cervix, and this is what you can tell here. This is a septated uterus. So we will see now some case. Here it's a septate uterus. You have no indentation of fundus and you have two cavities on the upper part. And this was obtained with a multiplanar view, or also it's possible to obtain it with a polyline omniview. This was obtained, it's another case, with a sonohysterography. That means it's black because you have some fluid inside. And from here it was possible also to do a really 3D rendering using the inversion mode. This is the cast of this uterine cavity. And this is another case using silhouette. So this is really nice. You can illustrate the case, but you will never use it on your daily practice because it's time consuming. So more important to remember, it's this possibility to do a section inside the volume and to give this kind of picture. And in case of septate uterus, what you have to do, you have to do the measurement of intercornual line, septal length, and because if you go to surgery, you need to know especially this measurement and this measurement. And this was one case before surgery and after surgery. It was not absolutely perfect, but you can see the septum is smaller than before. And why is it important? Because sometimes you have a more risk of miscarriage, and if the lady already had miscarriage with a septated uterus, you have to go for surgery and try to remove this septum. And this is a septate uterus and pregnancy. This was a lady before pregnancy, and she started pregnancy, and this is the septum, and this is a 3D rendering of the complete gestational sac with the embryo inside, and this is a footprint of this septum. And later in the pregnancy, it's not the same case, it's another case. You can see here the septum, and this view is from here. That means this is a 3D rendering. You can see the face, and this septum looks like a carpet covering the fetus. Not a carpet, sorry, a blanket. And this is another case with clearly seen later in the pregnancy with the septum here, and the fetus is in part of the uterus, and the other part you have some amniotic fluid. Bicorporal uterus, you have indentation of fundus here, two cavities and two cervix in this case, and it's not so easy to obtain and to show. So here what we did, we moved inside the volume to demonstrate that it's a bicorporal uterus and also with two cervix here. But it's difficult to obtain with transvaginal probe. Why? Because with transvaginal probes the volume is not so large and it's difficult to fit completely the uterus inside the volume. It's why in some situation you have to use, here it was the case, the abdominal approach, because when you use 3D with abdominal probe, the volume is larger. And this was a young lady because it was 14 years with hematocolpos. So you can see the two uterus, and this is the hematocolpos, that means the blood inside the vagina. We will see on this case how to classify. First, it's a bicorporal uterus, so it's a U3, and it was complete, so it's B. The cervix, it was with double cervix, so it's C2, and there was a longitudinal obstructing vaginal septum. That means for the classification, this is a type of this malformation. A septate uterus, and this is a bicorporal uterus. And if if you do the old method, that means hysterography, with hysterography it was not possible to differentiate this kind of uterus because it was possible to see only the uterine cavity but not what was outside. But don't forget, when you find a malformation of the uterus, the chance of finding a septated uterus are 5 times higher than finding a bicornuate uterus. That means if you find a malformation, it's quite frequent to be a septated uterus. Hemiuterus, that means the class U4. On sagittal view, it's quite difficult to see it. This is the endometrium. It was a uterus with small myoma. And this was a 3D rendering on the coronal view, that means the frontal view. This is not a sagittal view, this is a frontal view. And you can see, you do not have this triangular normal shape of the uterine cavity, but it looks like a finger. But when you have hemiuterus, you have to pay attention. Don't stop with this hemiuterus and say, okay, it's a hemiuterus. Always look on the side, because sometimes you have rudimentary horn, and especially you will see on this case, this was a hemiuterus here, and moving to one side, the other side here, you can see a rudimentary horn. And what is this? This is a part of endometrium inside here. So this was a situation, this hemiuterus, and here this is not an ovary, this is a rudimentary horn with the endometrium. So the risk of a problem is quite high, and I told the lady that she has to remove this rudimentary horn, but the gynae say no, the risk is low, we do not have to do it. So okay, and she came a few months after, and this is a hemiuterus, and this is a pregnancy inside the rudimentary horn. So they had to do a surgery to remove this rudimentary horn with the pregnancy inside. The class U1 is dysmorphic uterus. This is a usual aspect, and this is a T-shape, and this is hypoplastic. And hypoplastic and T-shape, it's quite similar because it's a small uterus, small uterine cavity, and the thickness of the myometrium, it's really bigger than the thickness of the width of the endometrium. And this is a rare case now, you cannot see anymore. It was possible to see it 30 years ago. It was a uterus with lady the mother took diethylstilbestrol during the pregnancy. It was a typical aspect. This was an X-ray, and this was made with 3D ultrasound. What is the place for the arcuate uterus? At the beginning, it was considered as the septated uterus, but now we consider more as borderline. That means it's not important. If you see an arcuate uterus, you have to consider this is a variant of normal. So now I am at the end of this lecture, and sometimes it's really difficult. Look at this uterus. It was a large uterus, and when I start with 2D, I thought maybe it was a malformation, maybe a bicornuate uterus, and it was really difficult to classify. But if you look at this, it was a dysmorphic uterus, but all the dysmorphic uterus are small uterus. But in this case, it was a big uterus. So in this case, I will tell that this is U1, and you can say it's not T-shaped, infantilis, but it's other. That means you don't know what is exactly, but you put it inside the other. And my take-home message is the 3D ultrasound is really the gold standard examination to do the assessment of uterine malformation, because it's easy to do it. You just have to do it after day 10 to just before the period. It's not so expensive. It's easy to obtain an appointment. Also, it's possible to use MRI, but the problem is more difficult to obtain the appointment, and also the cost is not the same. And I will finish with this situation. Look at this. This was, you can see, it was a septated uterus. You can see here a large septum, and this is an intrauterine device. So what does that mean? When they put it without knowing it was a septated uterus, this intrauterine device is not in the correct position, and maybe she needed two intrauterine device, and here it was too large, and you have two parts of the device plugged inside the myometrium. So, in my opinion, through the ultrasound it's easy to do it. So when you insert an intrauterine device, it's always better to know what is the shape of the uterine cavity, so it's better to do this before inserting an intrauterine device. So, thank you for your attention.
Well, there we are. An absolutely brilliant masterpiece from the master himself. And we move on to the next talk in this series, which I will be giving on the famous arteriovenous malformation. And let's see how much you enjoy this. And we catch up in a question answer session at the end of this entire session after this talk and the next talk. So here we go. Big hello to all of you, and my thanks to the Extempore Recurrent Pregnancy Loss team for giving me this opportunity to be with you here today to discuss something that has a tremendous bearing on daily practice of obstetrics and gynecology, and that is the uterine arteriovenous malformations. And I will, of course, discuss some other confusing pearls of language, if I may call them that, which is the enhanced myometrial vascularity, also abbreviated as EMVs. Essentially, what we like to discover when we have a clinical scenario related to an arteriovenous malformation or an enhanced myometrial vascularity, and the terms are really used interchangeably, is yes, altered texture of the myometrium, and when we light these up with colored Doppler, you see bizarre, huge amount of hypervascularity. You sample that with spectral Doppler, and you find there's lots of flow at the end of the cycle. You can do 3D reconstructions, but most importantly, sometimes you might require to have some drastic intervention, such as uterine artery embolization, in order to save lives. And so I will take you through how best these are recognized and managed. So coming to the point of the introduction to these lesions, let me first of all say there is this controversy between the purists versus the practical workers. The purists like to refer to the arteriovenous malformations as something that is present since birth, which is the congenital ones, and the practical workers realize that really what we're seeing is enhanced myometrial vascularity, and this could be either congenital or acquired, and by far the more common ones are the acquired ones. And what they represent is a short-circuiting of arterial venous circulation without the traditional intervening capillary bed. A few years ago, it was decided that EMVs was the phrase to be used when there was an association with necrotic products of conception, retained products of conception. but we now realize that they're used interchangeably, and in fact there's quite the overlap, and therefore we now just use these words interchangeably. Essentially, like I said, we look with the help of ultrasound in the perspective of abnormal uterine bleeding to identify areas of inhomogeneous myometrium, which light up hugely with vascularity, whether you use conventional color Doppler, powered Doppler, or radiant flow or slow flow. And then looking at the pattern, are able to recognize this. And depending on the clinical scenario, a decision is taken. So when it comes to this, the first thing we need to understand is the theories of origin. Why do these happen? And that really helps us understand why they can look so different. One, of course, theory that is very commonly propounded is that there is an erosive property of the syncytial trophoblastic tissue and the chorionic villi during placentagenesis in early pregnancy, and that results in the opening up of these bizarre vessels. There is then, of course, the theory by Dirk Timmerman of the intermediate stages of involution of the placental bed, and that again has a bearing. And the third, of course, is that venous sinuses become incorporated into scar tissue after there's a necrosis of chorionic villi. Well, irrespective of the theory, what really happens is that you can have areas which are inhomogeneous. We can not always make out how much of this is necrotic products of conception if it is near the cavity. That really requires either a trophoblastic signal or an HCG correlation. But more importantly, to realize that you can have areas like this, which may or may not be vascular. So it's not that every arteriovenous malformation will be vascular. It might have already burnt itself out, and therefore you might find vascularity only in a small area. Sometimes, of course, you're lucky and you find these little bits and pieces of tissue within the cavity, which then again, most of the times would, of course, be retained products of conception, but then they could just be little bits of necrotic endometrium sitting and lying there. And therefore, it's important to realize that, yes, there is no classical appearance, but appearances which are situations of high suspicion that you need to identify. So what really would we end up looking at? Well, you would find an inhomogeneous area, either small or big, within the myometrium. You may or may not find a thickened endometrium, and the thicker the endometrium and the more inhomogeneous it is, the greater the chances of retained products of conception, and therefore then those need to be handled before you actually handle the arteriovenous malformation. The degree of vascularity can be quite different from what is anticipated on the basis of the grayscale on ultrasound, and you can find small vessels, large vessels, vessels that just go on from becoming arteries to veins, and sometimes, of course, a proper capillary bed. And then depending on whether you are using power Doppler or slow flow, you'd be able to differentiate these vessels a little more. These two are the same case, the middle and the top left. And you can see how different the pattern looks when you use slow flow compared to conventional flow. And then, of course, the ultimate confirmation that, yes, indeed, you find this pattern with lots of high velocities at peak systole and lots of flows at the end of the cardiac cycle. You can use different methods of imaging within ultrasound to try and identify the extent of these lesions. One of them is multi-slice imaging, and the other one is a stick vascular reconstruction of these vessels, as shown here in the bottom figure. So all of this is used for a better demonstration and therefore better understanding of the extent of this particular lesion. Now, let me now take you through a sensitization process of the clinical scenarios where AVMs or EMVs may be evident. And the most common, of course, is a dilatation and curettage for a miscarriage. And that would be the situation where you would see most of it. And even before the dilatation curettage, sometimes these arteriovenous malformations become evident, although the vast majority become evident after the procedure. You can see them in association with retained products of conception, either from a natural miscarriage or a medically induced miscarriage or a surgical miscarriage. You can see them after cesarean deliveries. You can see them in cesarean scar pregnancies and after myomectomies. So that is the general common group where you find this kind of a pattern. And the pattern again is pretty much similar, that those areas of inhomogeneous myometrium will fill up with bizarre vessels with huge amounts of vascularity. The intermediate group where you not frequently but not infrequently see this kind of a malformation are those with placental polyps. Also in the medical terminations of pregnancy where we use antiprogesterones and prostaglandins, in necrotic endometrial polyps, and of course in degenerating or degenerated fibroids, as well as focal endometritis. So it's important to realize that a very similar morphological picture would be seen in all these conditions, and therefore it's not pathognomic of an AVM or an EMV. You really have to keep an open mind and be ready for any of these conditions to show up. Of course, a correlation with HCG would let you know whether there is any remaining necrotic products of conception or products of conception. Then there is this rare group where you can also find the malformation, and those are in the gestational tophroblastic neoplasias, endometrial cancers, the true congenital arteriovenous malformations, normal deliveries, and of course cervical cancer. So how do you put this into a clinical scenario? Well, the clinical thinking is this, that you have to have a high index of suspicion. So that's lesson number one, that in an abnormal uterine bleeding following a pregnancy event, you have to maintain a high index of suspicion that this may be originating from an arteriovenous malformation. What are the features of these lesions on ultrasound? Quite a large variety. The most common is a focal, non-specific heterogeneous lesion in the myometrium, poorly marginated. You really can't tell where the margins stop, whether it moves onto the anterior wall, how much of it actually moves into the cavity. So that's the most common appearance, really. The second, but very classical appearance, are these tubular channels, as you see here. These would fill up with blood when you put on color flow. And the third one would be the presence of a group of cystic lesions in association with an inhomogeneous myometrium. The fourth morphology, and all of these are not infrequent, is that you have a background of echogenic tissue, and within that cysts are of various sizes. And then that again would be a very good way of recognizing these. The important thing to remember always is that these can variably extend into the endometrium, which means that the inhomogeneity of the myometrium and the inhomogeneity of the endometrium blend with each other, and there is variably thick endometrium, and then you would need to differentiate how much of it is AVM and how much of it is really products, because the products will need to be cleaned out before you can think of what to do with the AVM. In fact, if you clean out the products, very often the AVM will disappear entirely on its own. So that is a situation that we should be aware of, the great variety of the spectrum on grayscale on ultrasound scans. Moving on, what are the features on color Doppler? There's always the classical feature of a bizarre hypervascularity. The flow is turbulent, which means you will find lots and lots of varieties of color, the blues and the reds, depending on what you have chosen. You will find more often than not multiple tortuous feeding vessels, and the purists actually believe that the classical congenital ones would have a single feeding vessel, but that's not necessarily true. And when you look at these with the help of spectral Doppler, as you see here, you will find high peak velocities and a low resistance flow. Low resistance means that at the end of the cardiac cycle, you will find a large amount of flow, as you see here at the end of each cycle. There has been actually a classification of the quantification, and Timmerman and his group suggested that if you have a peak systolic velocity value of 83 centimeters per second, these are potentially dangerous, and these would benefit possibly from immediate embolization. And if you have a peak systolic value between 39 to 83 centimeters per second. These usually indicate a less dangerous malformation. And if the values are less than 39 centimeters per second, these are usually safe and will often go away on their own without being a threat to the patient's life or hemoglobin. There is also a recent suggestion by several workers that we should just use 20 centimeters per second as a cutoff point, but that's semantics, really. Essentially, anything beyond 80 would mean that, yes, we need to act sooner and more drastically rather than just sit back and indulge in masterly inactivity. Do remember that, in these lesions, the vessels are in all directions. This means that when you try to measure peak systolic velocity, you may not be doing it correctly because you don't know how to correct the angle. How do you overcome that? You overcome that by what Trish described, and that is you use a small gate, a 2 millimeter gate, and you use it at 5 to 10 different sites, and then take the peak, which is the highest of those velocities, and then you can come to an answer. And that perhaps is a good idea, because really speaking, the vessels overlap, they're hidden behind each other, and you really can't tell where you got the signal from. So it's a good idea to realize that, yes, you take more than 3 or 4 readings, take 5 readings, and get your answer. Now, let me show you some examples to show you how differently these things can look, so that you carry this message home on pattern recognition. And there is this. So you have here inhomogeneous myometrium, a few odd hypoechoic spaces, poor definition between the cavity and the myometrial echoes, and when you switch on color, you find circular vessels which are sometimes thick, sometimes thin, and sometimes actually anastomosing with each other, which is why we call it arteriovenous malformation. And that would be the classical answer of a appearance of the arteriovenous malformation. You could have this, the cystic space that I showed you on grayscale, with layers and layers of vascularity around it. And the low vascularity you use, which means you come down from conventional Doppler to the classical power Doppler to slow flow, you will find more and more vessels. And then, of course, you have a very round-looking mass that you can have sometimes, just full of thick blood vessels, and it looks very dramatic on a 3D reconstruction. But there you are. It's a great way of understanding the lesion and a great way of explaining to the patient on what could be potentially threatening her existence. And then, of course, the simple appearance here of tubular spaces filling up with vessels that are somewhere thick, somewhere thin, and communicating with each other at various levels. And then, of course, do remember that sometimes almost 1/3 to 2/3 of the uterus can be occupied by these, and you should be aware of that. But most importantly, that not every patch of bizarre vascularity is necessary in arteriovenous malformation. This, for instance, was actually just a necrotic endometrial polyp with a large vessel leading to it. Yes, a few, there were odd vessels coming off the sides as well, but essentially not all vascularity is an arteriovenous malformation, and you might actually require just a cystoscopic polypectomy to get rid of this kind of a situation. The clinical background, of course, would be just abnormal intermittent intermenstrual bleeding. The other thing I want to sensitize you to about is the fact that although most of these vascularizations actually have a cavity component, it's not that everything that is inhomogeneous in the myometrium and partly occupying the cavity is necessarily an arteriovenous malformation. So here, for instance, is a poorly defined lesion, partly in the cavity, partly in the wall. And when you switch on power Doppler, you find peripheral vascularity. And that peripheral vascularity tells me that, yes, this is a fibroid with degeneration. Degeneration because it has an inhomogeneous appearance. And this one has a bunch of central vessels coming out of it. So when I see this, then I know that this is an adenomyoma, and definitely not an arteriovenous malformation. But this one, which pretty much passes off the same morphology except a little smaller, is really that pool of blood with a large feeder, and then you know that, yes, this is arteriovenous malformation. So you have to keep an open mind. abnormal uterine bleeding following a pregnancy event, high index of suspicion for an arteriovenous malformation, but not all of these heterogeneous myometrium with vascularity are necessarily arteriovenous malformations. What other investigations? Well, a serum beta HCG will give you a very good idea of the degree of trophoblastic tissue still left there, or also how remote are we from the actual event that resulted in this. The next really useful test is a CT angiography, which will confirm a lesion, assess feeders, be an embolization guide map if that's the kind of treatment you choose. And it's very useful in unstable patients with heavy bleeding and helps you to possibly triage to surgery. When you look at MRI, there is, of course, that problem of availability and cost. But importantly, to get a good image on MRI, you need a lot of skill by the technician or by the radiologist. And therefore, you have to be very careful. But otherwise, in general, when it is available, it gives you the best tissue characterization. So that's important. And then, of course, if you're really strong on your suspicion for what's going on in the cavity, either as a differential diagnosis or as retained products of conception, then a hysteroscopy would be a very useful investigation. To outline what we do with these once we see them, you have to understand the natural course, the various clinical features, and the treatment options. Remember that the bleeding associated with these may never happen. It could happen once and never happen again. It could happen again and again, and it could be variably severe. There, of course, is that very strong history of a pregnancy episode. And do remember that a large number of these would resolve spontaneously by doing absolutely nothing. Some of them may require uterine artery embolization or a hysterectomy, and some would respond to just medication or expected management. But decisions really would depend on future childbearing. So if she's not interested in childbearing, or she has an exsanguinating hemorrhage, recurrent, or once, or really, really bad, then the option would then be a hysterectomy. Treatments, of course, need to be individualized, and before you do any of this, the patient would need counseling. And after you've done everything, the patient will need to follow up with you to make sure that it's all really settled in completely. Let's talk a bit about these options. When it comes to the hysterectomy, it's really the treatment of choice if childbearing is not on the agenda. Also for emergency care in an uncontrolled bleeding situation. And of course, you would require a hysterectomy if she continues to bleed after a uterine artery embolization, because sometimes that process can fail. Remember that the option of an intrauterine Foley's tamponade can often stop exsanguinating hemorrhage and is worth trying out if nothing else is available. When it comes to uterine artery embolization, it's carried out by the interventional radiologist, and the indications are really recurrent bleeding and severe bleeding, or in the hemodynamically unstable patient who wants to preserve her fertility. And in that case, then the lesion is outlined, and you can use either coils or a gelatin sponge, balloons or cyanoacrylate to actually obliterate the vessels. You might need to obliterate more than one vessel. You might need to obliterate a whole leash of vessels, and you might need to obliterate the same vessel again and again to get an answer. And it works well in hands that are trained to look carefully at those bizarre vessels. But remember that hysterectomy and uterine artery embolization are really not the most commonly employed treatment options. Very often, if the patient is asymptomatic, the lesion just disappears, and then you just do expecting management with masterly inactivity. You could also have the options of estrogen and progesterone combinations or contraceptive pills, or you could try methyl-agonovine. Some people have, workers have tried out GnRH agonists, and they seem to work pretty well. And there are reports, of course, of danazol and prostaglandin F2 alpha as well. So all these possibilities are there, and really it's a matter of individualization. Do we have an algorithm which we can try? Yes, we have an excellent one from the group of Dirk Timmerman and Tom Byrne and Karen Grewal told us that once you identify the enhanced myometrial vascularity, then you assess the possibility of retained products of conception. And if that is there, then the approach becomes completely different, because then you need to remove those. On the other hand, if you don't have those, and your patient is hemodynamically unstable or has very heavy vaginal bleeding, then of course you will remove the products if you see them, and then consider the option of embolization, in which case you will inform the interventional radiologist, inform the anesthetist, and cross-match blood as you think you might require. But the patient who's stable, then you can just try expecting management and follow these patients up. And that seems to work a lot of the times, or medical management can be tried. And then, of course, the option that if you're strongly suspecting products of conception, then you would consider hysteroscopic removal and cleaning of the cavity. But then again, these patients must be reassessed 2 weeks post-procedure to make sure nothing is left behind. In summary, arteriovenous malformations and enhanced myometrial vascularity should be on the list in patients with abnormal uterine bleeding. Ultrasound with color Doppler is the investigation of choice, and treatment needs to be individualized depending on the amount of bleeding, the need for fertility preservation, and the patient's hemodynamic condition. And thank you so much for your attention. So the final talk on our agenda in this symposium is by Tom Byrne, and I look forward to his presentation. We know Tom requires no introduction to an informed gathering, but for those of you who don't know him, he's the chair in obstetrics and gynecology at the Imperial College London. He's also an honorary consultant at Queen Charlotte's and Chelsea Hospital and a visiting professor at KU Leuven. And I so look forward to his presentation. Thank you, Tom, for being with us today, and the floor is all yours.
Well, hello everybody, and many thanks for asking me to speak at this this meeting, which I guess in normal circumstances would be Ukraine. And of course, like everyone else who are taking part, I'm sure all of us delighted to be supporting you. Now, I've been asked to speak about ultrasound in relation to miscarriage, so I'll just share my screen if I may. And let's go. So in general terms, obviously what I'm going to talk about is diagnosing early pregnancy failure, because that's really the key role of ultrasound in this context. So in some ways, this is quite simple stuff compared to some of the lectures that you're going to be listening to. But actually, I would argue that whether or not someone has miscarried is really probably one of the most critical decisions that most people will make when carrying out a scan. And certainly in the UK, and I suspect it's the same in your country, every year mistakes are made. And you can see here in the most tabloid of all our UK newspapers, someone here has made a mistake diagnosis of miscarriage has been made, and the couple has subsequently found their baby was viable. And I think if there's one thing people expect doctors to get right, it's that their baby is alive or dead, which is not an unreasonable expectation, I would suggest. And here we have again in the Daily Mail. So critical that we get it right. And I think it's also important to understand that, you know, a number of scans will be uncertain, especially in early pregnancy. And if you look here at 5 weeks, chances of having a diagnostic scan somewhere between 10 and 20%. So turning around the other way, 80% of the time, you're not going to have certainty. It's going to be a pregnancy of unknown location or a pregnancy of unknown or uncertain viability. In 6 weeks, it's about 40 to 50% have a diagnostic scan. And even at 7 weeks, only 70 to 80% of pregnancies, when you scan them, will you have a clear diagnosis in relation to viability. So it's obvious that increasingly, you know, we do have situations where what we see on scan is not entirely clear, and we have to make decisions about when to see the patient for follow-up and whether or not the pregnancy is viable. It's not greatly helped by these very sensitive pregnancy tests, which happily tell women they're pregnant really some time before their expected period. And of course, they'll get the odd bit of spotting now and again, or maybe some pain, and they'll come for a scan very early. And of course, we won't see anything on the scan. And really, the only thing they're going to gain is the possibility of inadvertent termination of wanted pregnancy. It's unlikely that they'll run into trouble with an ectopic at that stage of gestation. And of course, we won't see a pregnancy when we scan them. So this is unhelpful. So when can error and harm occur? I mean, pretty well any time, but you can see in the earliest stages of pregnancy, where you can miss an ectopic pregnancy, or misclassify a PUL, or give methotrexate for the wrong reason. When we measure a gestational sac incorrectly, when you start judging whether this is an embryo, presence of a heartbeat, it's often mistakes happen with multiple pregnancy because structures appear to appear somewhat later, and the HEG levels often don't act exactly as one might expect. And I just argue that perhaps we only are sufficiently rigorous when the pregnancy looks like a baby. Sometimes when you look in earlier pregnancy, people are really not careful enough. Now, if we look at previous guidelines, which were developed back in the past, if we go back to 2011, rather shockingly, it was very clear that we weren't even getting the diagnostic criteria on which to base the diagnosis of miscarriage correct. There are 4 seminal papers in the White Journal. This one is a systematic review, which showed very clearly, if you look here, this is specificity, that the false positive rate for the diagnosis of miscarriage in various papers which was being used to formulate guidelines could be as high as 35%, 12%, 7%. And these studies were based on very small numbers with really very significantly wide confidence intervals, and were, when we reviewed these, rather alarming. We also carried out an inter-observer variability study of measurements. And again, you can see that if we look at the old cutoff value on which we used to base the diagnosis of miscarriage of 6 millimeters for an embryo, between 2 very experienced operators, you can see this could be between 5.4 and 6.7. And for a 20 millimeter sac, it could be 17 or it could be 24. Very significant differences when it means that this is the difference between making a diagnosis of miscarriage or not. And then in a big study, a relatively big study of 1,000 women attending early pregnancy units in London, where the endpoint was viability at 11 to 14 weeks. In other words, if an error is made, this would likely be a termination of a take-home baby. You can see here that for the cut-off values at that time, i.e., if someone had an empty sac of 16 in the States, the false positive rate was 4.4%, so about 1 in 20, with quite wide confidence intervals. In the UK, it was 20 at that time. So if you said someone had miscarried because they had a gestation sac of 20 millimeters, then there is still a significant false positive rate. And again, relatively wide confidence intervals, so you'd be getting it wrong about 1 in 200. So this was highly concerning, considering these cutoffs were different around the world. And when you look at the embryo size, here we have 5 millimeters, which was being used in America, and you can immediately see there's a big problem with specificity. False positive test rate for miscarriage, 5 millimeters. It's about 1 in 12. Again, with quite wide confidence intervals. So this is hugely alarming and demonstrably unsafe. And 6 millimeters is not watertight because we didn't have data on that for this study. So it's very clear that there was a problem about diagnostic criteria. And based on these data, guidelines were changed within a week by the RCOG in the UK and then subsequently throughout the world. So now you should only consider a diagnosis of miscarriage with an empty sac with an MSD of greater or equal to 25 millimeters with no obvious yolk sac or embryo, or an embryonic pole with a crown lump length of greater or equal to 7. And I should say that in these circumstances, you should always, if you believe there's a miscarriage, have that scan checked by a second operator as well, because that is critical. Now, the college at that time, and I think this was mirrored internationally, they said, well, if there's any doubt about the diagnosis, in other words, if the sac's 20 millimeters and it's empty, you can perform another scan at an interval of 1 week. But if you go around the world, actually, there's quite wide variations in when people bring people back. Some say a week, 10 days, 2 weeks. Obviously, that shouldn't be the case because there has to be one correct approach. The other thing that we noticed was that no growth in a sac or embryo is strongly suggestive of a non-viable pregnancy in the absence of embryonic other structures. That's just an important point, but again, it's not diagnostic. So this led to a consensus conference arranged by the Society of Radiologists in Ultrasound in the States, which was led by Peter Duberlin. I was fortunate enough to be on this. And this was a consensus document based largely on our data, and they came up with these diagnostic findings for pregnancy failure, the same ones I've just outlined from the RCOG. And they suggested that if you've had a scan that showed a gestational sac, in other words, an empty sac, and there was no embryo with a heartbeat after 2 weeks, then that could be called a miscarriage. And if there was a gestational sac with a yolk sac but no embryo, if you didn't see an embryo, you could pull that back to 11 days. So in general terms, it's reasonable to say that if you have an uncertain scan, you bring them back at 2 weeks. And I think that was reasonably sensible. And I think that remains, in my eyes at least, the right thing to do. And I'll show you some data that perhaps is a bit more nuanced than that, but it's reasonable, and I think can be reasonably adopted into guidelines. There are also a number of findings which are suspicious of miscarriage, but they're not diagnostic, and I'll come on to those later. Following the paper from Yazan Abdallah, we continued to collect data and then subsequently published this paper. The lead author, Jessica Preisler, who's now a consultant in Santiago in Chile. And this was an extension of the 2011 study, and now we have over 2,550 pregnancies of uncertain viability followed up in 7 London hospitals. And I'm not going to show you all the data, but you can see that we agreed with previous criteria. As you can see, we absolutely showed that the criteria based around an empty sac of 25 and an embryo crown lump length of 7 is safe with a high level of specificity. You can see 100% specificity with actually pretty tight confidence intervals. So I'm pretty happy with that. I just want to draw your attention, however, down here, where we also found that on repeat scan, if there was no visible embryo and a mean sac diameter of more than 12, then actually it was reasonable to return at 7 or more days for a repeat scan. And if there was no embryo or embryo heart activity visible, that was a miscarriage. Similarly, if the embryo, if the mean sac diameter was less than 12, then after 14 days, if no embryo heart activity was seen and the sac diameter had not doubled, that again had a very high level, as you can see here, of specificity. So when you bring a patient back in the event of having an empty sac, depends on the sac size, which intuitively makes sense. the sac is over 12, you can bring it back earlier. And if the sac is less than 12, you perhaps need to wait at least 2 weeks. I think in general, however, what this data is showing is that a very safe approach is bring the patient back in 14 days in the event they have an empty sac. And we clearly showed that if you've seen an embryo with no heartbeat, if on repeat scan it still has no heart activity after 7 days, this is also safe. So in other words, for an embryo with no heartbeat, you can bring it back in 7 days. If there's still no heart action, it's a miscarriage. And I've already discussed what you need to do with an empty sac. I think it's very important also to give women an idea of what's going to happen, because quite a number of women using these criteria will need to come back for a repeat scan, and they kind of want to know what's likely to happen. So you need to manage their expectations. And there's a real point to this, because, you know, the difference between expectations and reality is frustration, disappointment. And we know there's a significant psychological consequence to miscarriage. And we think that perhaps giving people information about the likely outcome when they need to come back for repeat scans is helpful in order to prepare them for what the likely outcome is going to be. So education and accurate prediction. And I think also from a societal point of view, we don't help ourselves, because a lot of women turn up for scans to see us with no idea about the possibility of miscarriage. And when you look at these sorts of magazines we get in the UK at least, there's no mention that pregnancy could fail. And it might be helpful occasionally if the media, magazines and so forth were a little bit more realistic and maybe produced better information for the unfortunate 25% of pregnant women who are sadly likely to lose their baby. I think more information would go a long way to managing people's expectations and being realistic about what can sometimes happen in pregnancy. And I say that because we know that there is significant post-traumatic stress, following early pregnancy loss. And you can see this paper initially by Jessica Farron. 3 months after miscarriage, 39% had significant post-traumatic stress symptoms. And we know that at 9 months, that is still about 20%. So this is highly significant, you can see from this pilot study. And I draw your attention to further publications that we've had in the American Journal, just to get more information on this. So it's important that we think about how we manage women in these circumstances. Now, if you do have uncertainty in pregnancy, we know it can be associated with anxiety. And you see here, if you have an uncertain diagnosis, levels of anxiety are retained in this study. And if you're given a certain diagnosis, the level of anxiety does appear to decline after the scan. So managing this uncertainty, I think it would be helpful. You see this paper from Davison, where they used a test to predict viability in early pregnancy. This was a prospective randomized study. And if you look at the anxiety scores at day 7, they appear to be at least less when the prediction of viability was given, which we feel would be helpful. Now, what are indications of a poor outcome? Well, I showed you this table from this paper. And if we look at these findings, which are common sense and are suspicious but not diagnostic, basically, if you see an embryo with no heartbeat, then the prognosis is poor, but it's not guaranteed that the pregnancy was failed. So, you can advise the woman that, the outcome is likely, unfortunately, to be miscarriage, but you have to check in a week. Same with sacs under the threshold as well. If you don't see an embryo greater or equal than 6 weeks from someone's last menstrual period, the empty amnion sign, which we'll come on to, the large yolk sac, and the small gestation sac in relation to the size of the embryo. All these are signs of likely miscarriage, but they're not definitive. And just to emphasize, we do not take into account the last menstrual period when we're making a diagnosis of miscarriage. Even if people say, oh, I'm sure that I'm 8 weeks and you can't see something, you have to ignore that, because we have found from our experience that people are not accurate with their dates and sometimes mistakes are made. So likely miscarriage, you can see here, pregnancy of uncertain viability. You've got a very small sac in relation to the embryo, which is classically, likely to miscarry, but not definitive. And we also have here the empty amnion signs. This is paper from Dooley, from Davor Jurkovic's group at UCL, which you can draw your attention to. And actually, you can see actually it has a pretty good diagnostic performance with a high level of specificity. But in this study, it only applied in 15% of cases. So again, it's not one of the diagnostic criteria currently. It may well become so once larger studies have been carried out, as you can see here. And you can see, I mean, it may be useful because using this, you could have potentially reduced follow-up scans by 11%. But it needs to be validated externally, and that as yet has not been done. So you should not be using this currently to make a diagnosis of miscarriage. Again, just to show an example of the empty amnion sign, usually you see the amnion at 7 weeks, as you can see here. You can see a yolk sac, but there's no obvious viable embryo, highly suggestive of miscarriage. Intrauterine hematomas, people often think these are associated with miscarriage, but this very good paper by Mayor Al-Mamar from our group in a large population of consecutively recruited women in early pregnancy, 27% had hematomas, and we found no association with an increased risk of miscarriage of hematomas. However, a hematoma is associated with other antenatal complications, such as preterm labour, and therefore it's wise that in women with a subchorionic hematoma, you follow them up as a high-risk pregnancy. However, you don't need to tell the woman that she is at increased risk of miscarriage. And you can see here a typical intrauterine subchorionic hematoma here does not increase risk of miscarriage, which is perhaps surprising, but that's what the data shows. Other viability models, the best one probably, I think, in my view, is this one, which was developed by Cecilia Bottomley. You can see that this model, which is based on an empty gestation sac and an MSD of less than 25 plus yolk sac and a CRO of less than 6. This was the old definition of PUV for this study. And you can see that the age, the bleeding score, gestation age, mean sac diameter, and presence or absence of the yolk sac was used in the model with a reasonable area under the curve. In this study, with the new definitions of the PUV, this, in fact, had age and the bleeding score, and then when you introduce these ultrasound criteria, the combined model had an area under the curve of 0.924. So this is actually a very good diagnostic performance, and this has now been validated. As you can see here, this was 1,435 consecutive pregnancies, and the outcome was 11 to 14 weeks. And you simply look at what's going on with the pregnancy or the pregnancy that you're examining, you assign a score, and basically from the sum of the points that you have, you can give an estimated chance of viability. So -4 is a 50% chance of viability, +8 is 99%. So using this simple scoring system, you can pretty much tell the woman what's going to happen with respect to the pregnancy. It's contained in a simple app now that you can download, or you can download it free as an Excel spreadsheet from the internet. And you simply go into the pregnancy app, choose the viability model, and enter your data, and then you come up with the results. So in this case, like, the risk of miscarriage is 96%, because she has. And that's because you can see she's got a sac of 18 and she's got a yolk sac that size. That means that she's highly likely to miscarry. Other people have tried to use pregnancy hormones to predict viability, but none of these studies really are big enough to include the use of hormones such as HCG or progesterone in the diagnosis of miscarriage. And this French paper here clearly shows that there is a difference in progesterone, as you can see, between pregnancies that miscarry and pregnancies that don't, as well as the HCG and the HCG ratio. But these populations are too small, as you can see here, 41 and 66, to come up with accurate sensitivity and specificity data. And so again, you should not be using progesterone or HCG in your clinical practice to make a diagnosis of miscarriage. Other markers exist. You can see here we've tried to look at AFP. We've looked at the HCG ratio in PUVs. It has an area under the curve of 0.85. It's just not good enough. Progesterone 0.78, again, not good enough to be specific enough to make sure that if you tell someone they've miscarried, they absolutely 100% certainty that that is what's happened. Moving forward, I think there are some other markers. Kisspeptin is looking promising. You can see here between controls and miscarriage with a reasonable area under the curve. compared to multiples of the mean for a single measurement of HCG. But at the moment, the future probably lies with a combination of biomarkers associated with ultrasound information. So, for example, it may be in the future that if you have a 16 millimeter MSD and a progesterone of 3, that is definitively a miscarriage, but we're still collecting data to demonstrate that. So, pregnancies near the decision boundaries for miscarriage are likely to miscarry, but definitive diagnosis can't be made. We know that there are a number of ultrasound markers that indicate poor prognosis, and so we can inform women of the likely outcome of the pregnancy to try and manage their expectations. But these are not definitive, and they do not contribute to the criteria required to make a diagnosis of miscarriage. I think it's just important, really important, how we handle women in this situation and their partners, because there is a very significant psychological impact. And there is some evidence that managing expectations for those needing a repeat scan may reduce anxiety. I suspect moving forward, the best approach would be to combine factors into a scoring system or model, but as I say, the data aren't there. I just want to make a plea, really, that in early pregnancy, it's really important that people who scan early pregnancies are trained, the equipment is good, and that you have senior supervision. Anybody, when he makes a diagnosis of miscarriage, should have the scan checked. Empathy and compassion when dealing with people with early pregnancy failure is absolutely essential when you speak to women. I mean, if you don't realize that, I would urge you to log on to the ISFOG website and look at the last plenary discussion session of the recent World Conference, when I actually was chairing a conversation with women who sadly have had miscarriages, and that you will see how important compassion and empathy is. You have to use rigorous diagnostic criteria and stick to them using the cutoff values that I've talked about. Do not take into account gestational age, because that's been accounted for. You need to be very rigorous about when you bring patients back for repeat scans, because it matters. So you shouldn't be saying, well, in some it's 7 days, 10 days, 14 days, and just using your, clinical view. The data shows that, for example, if there's an embryo with no heartbeat, it's 7 days, and for an empty sac of 12 millimeters, it's 14. Remember that in early pregnancy, expectant management is unlikely to be harmful. So if you do nothing and repeat a scan, and it's unlikely to be harmful. But in the event that women miscarry, again, it's important they are given realistic information. Expectant management of miscarriage can be unpleasant. You can have heavy bleeding. It can be painful. It's not just a period. And it's really important that women understand that, and they have a number to call if there's a problem. And I'd say, first do no harm. As they say, most of the time it's safe to do nothing. But, you need to give people information about what may or may not happen and make sure they have a backup in the event that they bleed heavily or there's a problem. And I just would like to end by saying that if you want to read anything about the care of people in early pregnancy, read this report, which was chaired by my mentor and my boss when I was a fellow, Stuart Campbell, looking into a number of cases in an area of the UK where mistakes have been made about diagnostics. And he said this, that irrespective of gestation, all pregnancies deserve the same level of competence, the same diagnostic criteria and a robust criteria, the same care and compassion in the event of pregnancy failure. And I'll draw your attention to the States, where they've said, addressing the issue of diagnostic error is a moral, ethical, and public health imperative. So it really matters what you're doing in early pregnancy. So just make sure that you act with compassion, that you are using very robust diagnostic criteria, that the people who scan are experienced and that they're trained, and there are senior people available to check scans when necessary. And remember, the death of an early pregnancy should be regarded as of equal significance to that occurring at a later stage. And if you remember that, you will not go far wrong. I'll just end by drawing your attention to a webinar next Wednesday, which you may be interested. You can just scan the QR code, and this is about IOTA terminology and models. So we'll all be there, and perhaps you'll be interested in tuning in. Thank you once again for inviting me to speak at the meeting. it's a great honor to be asked to present to you. And I hope the rest of your meeting is a great success.
We've had a series of very groundbreaking information here, and we've gained a lot. We have a few questions before we close this session, and let me take them one by one. There was a question for Professor Igel-Wollmann. He's not able to join us at the moment. The question was, does the type of closure of the cesarean section influence the niche and its dehiscence, and would it make a difference? We have studied this in detail several years ago on the influence of single layer closure and multiple layer closure, and it has no impact on what is going to be the final morphology. And the appearance of the scar indeed is an individual response to a surgical insult, and it's nothing to do with the complications, it's got nothing to do with sepsis. And what we do come across is the fact that anybody but anybody with a completely uneventful recovery, if I may use the word, from pregnancy, will also have the chance of an abnormal scar thickness. And it's not just those who've had complications. So we don't have the last word out on that as yet. We also have another question on, and this is on whether a saline infusion, not a gel infusion, can help us to identify retained products of conception in a uterus from an enhanced myometrial vascularity. And the answer there is that the question here is whether the products of conception are attached to the uterine lining or they are not. So the ones that are fixed to the so-called decidua are the ones that will not move one way or the other. So truly speaking, we will not have the answer with the saline infusion. And since we're concerned about viable versus non-viable tissue, the HCG remains the only value we have so far. Yes, even with non-viable tissue and with patients who will empty this out completely on their own without any medication, we can still have high levels of HCG. And therefore, HCG will not prognosticate the condition. It will just diagnose the condition for you. So again, something where we use HCG to confirm that it's not products of conception and treat accordingly. But more often than not, it's doing nothing and watching it and repeating the actual ultrasound with powered Doppler and 3D after a period of 2 weeks. So that's the kind of thing we follow. I'm not sure whether there are any other questions in the chat. And so there we are for this. We do welcome questions. So if you have any, you could email them to us and we'd guide them and see from where we can get the answers for you. And on that note, I'd like to thank our organizers, Extempore, for bringing us together again. You are contributing so much to learning on this planet. I wish all of us who are with you can have our prayers with you and have a peaceful answer in your parent country as well. And praying at the end of the year for peace on earth. Let's send this on a positive note and hope that next year, 2024, will indeed be a year of peace and love rather than what it has turned out to be in 2023. Thank you very much.
We had a dream of Sonio, and Sonio made it.
Sonio, pour moi, c'est vraiment la sécurité de l'examen. Voilà. C'est aussi un gain de temps et un gain de concentration, je dirais.
With Sonio, we cover everything from screening to quality control to workflow to improving doctor-patient relationship and to improve the expertise of a doctor in rare situations.